Well, good afternoon. Welcome to Medical Board of California meeting in Santa Ana, April 27, 2017. I want to ask all of us to please turn off our cell phones to silent and make sure they're off the table so we can avoid feedback noise. You may notice board members accessing their laptops during the meeting. They're using the laptop solely to access the board materials that are in electronic format. This is an official business meeting of the Medical Board of California, and as such, disruptions of the board's business will not be tolerated. We have a designated time on the agenda for public comment and ask for public comment on each item. I ask that you be respectful of the need to conduct the board's business. Should anyone disrupt the meeting, I will ask the person to conduct him or herself in such a manner that permits the board to transact its business. This meeting will be available via teleconference. Individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconference process. For those members of the public participating via teleconference, please wait until the moderator has introduced you before you make your comments. To request to make a comment during the public comment period, press star and 1. You will hear a tone indicating you are in queue for comment. If you change your mind and do not want to make a comment, press the pound sign. Assistance is available throughout the teleconference meeting. To request a specialist, press star 0. Each person will be limited to 3 minutes per agenda item. During agenda item 2, public comments on the items not on the agenda, the board has limited the public comment period for individuals on the teleconference to 20 minutes. In addition, public comment from the individuals here at the meeting will also be limited to 20 minutes. Therefore, after 20 minutes, no further comments will be accepted. During public comment on any other agenda item, 10 minutes will be allowed for comments from individuals on the teleconference line and those in the audience. After 10 minutes, no further comments will be accepted. Business Service Office staff will be assisting me with receiving the public comments via teleconference during this meeting. The board welcomes public comment on any item on the agenda, and it is the board's intent to ask for public comment prior to board taking an action on any agenda item. If for some reason I forget to ask public comment on agenda item and you wish to speak on that item, please raise your hand to come forward and you will be recognized. I would like to request all speakers to complete a presenter slip so I can call you by name at the appropriate time, and that record for this meeting will be full and complete. However, this is voluntary. Please give the slip to Ms. Toof. Ms. Toof, identify yourself. Thank you. I'll do my best to call upon everyone who has supplied a slip for the agenda item and recognize those who wish to make a last-minute comment. I want to remind all speakers to stay on the topic and keep your comments to 3 minutes or less. We plan to end the meeting today around 6 p.m. I would like to introduce Kim to introduce the people.
Actually, in our audience today, we usually have Christine Lawley, but unfortunately, she actually had another engagement. So today with us from the Department of Consumer Affairs, we have Jonathan Burke. So, welcome.
Thank you, Kim, and I would like to call the meeting to the order and ask Ms. Toof for a roll call, please.
Dr. Bolat?
Present.
Dr. Bishop?
Here.
Ms. Feinstein? Dr. Hawkins?
Here.
Dr. Kraus?
Present.
Ms. Lawson?
Here.
Dr. Levine? Dr. Lewis?
Present.
Ms. Pines? Here. Ms. Sutton-Wills? Ms. Durwormuth?
Here.
Ms. Wright?
Here.
Dr. Yip?
Here.
Dr. Gonadev?
Here.
Thank you.
Thank you. The quorum is present. I would like to remind the members again that we'll be taking a roll call vote on all action items. Moving to the agenda item 2, public comments on items not on the agenda. Do we have any slips? Anyone like to make a comment? I don't have any slips. Any comments on the telephone?
Yes, one from the line of Eric Andrus with Citizen. Please go ahead.
We can't hear. Can
Everyone,
you-
I called into the October 2016 meeting and explained to you all how Carrie Webb has been breaking the California Public Records Act law. I asked at the time for this to be made an agenda item, and it's even reflected in the minutes. However, the January 2017 meeting came and went, and now here we are at the April meeting, and it's never been put on the agenda. Ignoring topics that you don't like won't make them go away. A fellow advocate just said to me today that they find it outrageous that the medical board is being so obstinate in working with me. She said it would behoove them to work with me instead of against me. Kimberly Kirkmeyer ignores all of my emails. I wrote to Cassandra Hawkinson about a matter of a couple of weeks ago and 2 subsequent emails, and she's never responded. And it seems that Carrie Webb pretty much only replies to innocuous requests or when the public requires her to. I've been trying to keep the board members themselves informed, and none of you have ever replied either. Judge Feinstein's emails are now bouncing back. I asked Carrie Webb to forward an email to Judge Feinstein in regard to the Public Records Act, but never received a response from either of them, so I have no idea if my email was passed on or not. Over a year ago, when I requested a report of all the doctors for the last 10 years with sexual misconduct charges, Carrie Webb told me it wasn't possible to send me such a report unless I pay the board to have a programmer create a report that would cost me $1,100. I find that absurd, as the most basic home database software can create that kind of a report for any field within a database. If your software truly can't print that out, you should be getting a refund from the designers. Instead, I hired an old high school friend to design a new website, and I'm actively entering every doctor listed in the medical board alert into our system, which is now available to the public. You can access it at forpatientsafety.org. It includes most of the information from your Breeze website, but in a clearer, easier-to-use format, and consumers can search for doctors using any field listed in the website. I'm very close to having every doctor listed from alerts sent out in 2017, and then we'll start working my way backward. The information will be readily available in a Google search, including all of the public documents that you all still have missing from Breeze, and that's around 15,000, I hear. I'm also documenting all the missing documents I find and any other problems with Breeze in a public spreadsheet that I've made available to Carrie Webb, but she seems to be ignoring that as well. So if you have doctors complain about their information now being so readily accessible in public, you can tell them to thank Kimberly Kirkmeyer and Carrie Webb for being so unhelpful. The harder you all work to ignore me, the harder it makes me work to keep the public safe, since you're not. Until next time.
Thank you, Mr. Andrist. Any other comments on the phone?
From the line of Khadijah Leahy with President of Golden State Medical Association. Please go ahead.
Good afternoon. This is Dr. Khadijah Lang, President, Golden State Medical Association, and I would just like to inquire as to, I didn't see anything specific on the agenda, so I wanted to find out, will we in fact be getting any follow-up on the issue that I raised at the January public meeting regarding narcotics and their availability in inner-city pharmacy neighborhoods? So I guess this is a comment section, so you can't respond, but I'm just hoping that we will be getting some follow-up information as to what was determined, or have we made any progress on the concerns that Golden State expressed about doctors being able to prescribe prescriptions to their patients for controlled drugs, and those patients that live in underserved medical communities would still be able to actually get the prescription filled at pharmacies. Thank you.
Thank you, Dr. Lang, and Ms. Kirshmer will talk to you, and it's mostly a pharmacy board issue, but we'll talk to you. Thank you. Any other comments on the telephone?
No other comments.
Thank you. Let's go to the agenda item 3, approval of minutes from January 27, 28 meeting.
I move to approve the minutes from that meeting.
Okay, so are there any comments from the board members? Any comments from the audience? Any comments on the phone?
No comments on the phone.
Thank you. Ms. Toof, roll call, please.
Dr. Bolat? Dr. Bishop?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Ms. Sutton Wills? Mr. Warmoth?
Aye.
Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev.
Aye.
Thank you.
Motion.
Personal privilege.
Go ahead, please.
May I inquire if the thermostat is set that it only pleases everyone? Should have warned.
Yeah, I think Ms. Toof was actually checking in to see, and one concern we had was that they might go to the completely opposite direction. Then we'll be shivering without some extra clothes on, but yes, Dr. Cross. Okay, thank you. We'll move to the next item, which is the President's report. That's me. So what have we done? Ms. Pines and I worked, this is the sunset review time, so actually Ms. Pines and I worked closely with the staff to prepare for the board's sunset review hearing. We met with the chairs of the Senate and Assembly BNP committees, answered any questions they had regarding the board and its sunset report. Staff also met with the other members of these committees prior to the meeting. The Senate and Assembly BNP committees had specific items that the board had to provide testimony at the hearing, and Ms. Pines and I worked with the staff as we were delegated to prepare the testimony. In addition, after the hearing, we worked with the staff on the preparation of responses to the sunset report background paper that was issued prior to the hearing. The responses were submitted to the Senate and Assembly committees on the due date, which was 30 days after the hearing. As you will hear later during the legislative report, many of the items requested by the board for legislative change were included in the sunset bill. There were also items we did not request on the sunset bill, but all our items were included. I would like to take a moment to thank Senate BNP staff really for their hard work on the legislation. In addition, on Monday, I testified at the Senate BNP committee hearing on Senate Bill 798, which is the board sunset bill. Ms. Samo will provide more information on the bill, but I testified on those sections that were requested by the board. We support those because we requested them. Since the last meeting, Ms. Pines and I had calls with executive staff to discuss board projects, and I have met with the new Director of Department of Consumer Affairs, Mr. Dean Graffalo. We look forward to working with him in the future. I have had the opportunity to provide presentations to physicians about the importance of the laws contained in the Medical Practice Act and ensuring that they know the laws and remain in compliance. I again encourage the board members to offer themselves to organizations that they will be affiliated with to provide updates on the board and to explain board processes in an effort to educate physicians on the functions of the board. Since the last board meeting, there have been no committee assignment changes. However, if any member wishes to change their committee assignment, please feel free to contact me or Ms. Kirschmeyer. Are there any questions from the members? Okay, any comments from the audience? Any comments on the phone?
No comments on the phone.
Thank you. Moving to the agenda item 5, board member communications with the interested parties. I will repeat this every meeting usually. That is, I'm involved with multiple organizations including AMA, AMPAC, CalPAC, and so on. And I do meet as a member of their boards, but never bring up the medical board issues. Try to keep as separate as possible. Any other members to report? Thank you. Is there a public comment on this? Any comments on the phone? Okay.
Any callers on the phone?
There are no comments.
Thank you. The next item is agenda item 6, discussion and possible action on 2018 proposed board meeting dates. Ms. Kirschmeyer.
Well, good afternoon. I'd like to draw the members' attention actually to a new document that was placed in the packet that was on your table there under the legislative. There are new dates on this new amended version. I believe this is also in the back table. So the reason that I had to do the amended option for board meeting dates was I found out via staff that January 23rd to 25th is actually a wine and food festival in Sacramento, and I'm afraid that if we have the January 25th and 26th date that same weekend, we're really going to have a hard time finding a hotel in Sacramento, and as you know, we have a hard time finding a hotel in that area, so I think it'll make it even harder. So I'm proposing that we actually move the January meeting up to January 18th to 19th. We could move it a week forward into February, the first weekend of February, but that also has its own issues because, again, we have to set the meetings to where we keep as much time in between cut down and usually try to set it about 13 weeks in between our board meetings because of the disciplinary cases and the need for interim meetings. So at this time, there still is that opportunity for the 25th and 26th if that's the best for everybody's calendars, but that January 18th and 19th or the 25th to 26th would be in the Sacramento area. Then the options for the next meeting are actually April 19th to 20th or May 3rd to 4th. That would be, the Federation meeting is actually the 26th to the 28th. At this time, if there's no change in the stance in California, this meeting actually is in North Carolina, and we actually cannot travel to North Carolina. So it may not be an issue, but I don't want to kind of go into it thinking that that may get changed before that time. So at this time, we're recommending either the 19th to 20th or May 3rd to 4th in the Los Angeles area. And then July 26th to 27th in San Francisco and October 25th to 26th in the San Diego area. So at this point, I would leave it up to the members, to those first two, which would be the best, or if they have a proposal.
Dr. Cross.
Thank you. Regarding the January date, if it's moved off to the 25th to 26th, the 18th to 19th is better for my schedule as the first Thursday of each month I serve the veterans. Similarly, the April/May date, the April 19th to 20th is certainly better. And the October date is problematic in that I am committed to a meeting in Chicago those days. So if it would please the other members of the board and if it would meet their guidelines to consider the October meeting for the 18th to 19th, that would be preferential for me. But I know that I'm not required to personally be at every board meeting. So it's not my intention to create inconvenience.
Thank you, Dr. Cross. Dr. Lewis.
We also have to check on religious holidays, because at one time we were doing some meetings and it was close to one of the holidays, so that's gonna, we need to check, make sure it doesn't conflict. Make sure it doesn't conflict with a religious holiday, please.
Any other comments? Kim, I can tell you about that. The days we should avoid whatever we can to do it on the days of the wine festival. The longest line for Starbucks I saw was during that festival. It was just awful.
So the 18th to the 19th would actually, it'll work for staff. It shortens the time between our October this year and next year. And if we do that April to 19th to the 20th, that's actually the best date for that as well because of the timeframes.
Are you able to reconsider October or do you need to stay at the 25th?
No, October would be, it would be fine to move it up to 12th, and it might just mean that we have an earlier meeting in 2019 in January, but that would be fine too, moving it up to October 18th to 19th. So I'd actually like to ask for a motion to move those dates.
Can you repeat those dates up?
Yes, so at this point, it looks like for the best of members, from what I'm hearing from comments, it would be January 18th to 19th in the Sacramento area, April 19th to 20th in the Los Angeles area, July 26th to 27th in the San Francisco area, and October 18th to 19th in the San Diego area.
I so move those dates, but you will check on holidays.
Yes.
So that's my motion, to accept those dates.
Okay. Do we need a roll call on
We
it?
do.
Okay, roll call, please. Now, before I do, any comments from the audience? Any comments on the phone?
Comments.
Dr. Gonda, before you take the roll, one thing I do want to say, just like as in happened this year, if we're not able to find a hotel within that area, like Los Angeles area, it may be that we're here in Orange County again, but we'll try to keep it central to LA-ish area.
Orange County is good any day for me.
For me too. Driving.
Maybe not.
Okay, so you ready? Okay, roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Wormuth?
Aye.
Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye,
Thank you.
motion passes. Okay, oh, Jennifer time, so move to agenda item 7.
All right.
Discussion on possible action on legislation regulation, Ms. Amos.
So please refer to your legislative packets. You should have gotten some updated documents, an updated tracker list, and several updated analyses and bills. So on your tracker list, the bills in blue are either two-year bills or bills we've already taken positions on. So these do not need to be discussed at this time. The bills in green and the one bill in pink will require discussion and a position. So I'm going to move on forward to the first bill in green, which is AB 148, Mathis. This bill would revise the definition of a practice setting for the purposes of the Physician Corps Loan Repayment Program eligibility, and that program includes the Stephen M. Thompson Loan Repayment Program, or STLRP, and the Physician Volunteer Program, to allow community clinics and physician offices that are in rural areas to be eligible if 30% of their patient population qualifies as medically underserved. The current practice setting definition specifies that community clinics and physician offices are eligible for the program if 50% of their patient population qualifies as medically underserved. This bill only changes that definition for rural areas. Urban areas still must meet the 50% threshold in order to be eligible. This bill would also specify that the revised definition only applies to program participants that enroll in the program on or after January 1st, 2018. This bill is designed to give rural areas a greater chance to obtain the benefits of the STLRP and recruit physicians to these areas. According to a report submitted by the Health Professions Education Foundation, only 15 of the total 126 STLRP awardees were in rural areas in 2015-16. Although the board originally supported the bill in 2013 that added the 50% requirement, it appears that some rural areas cannot meet this requirement and as a result are not eligible for the program. This bill will not increase the funding for the program, but it will expand eligibility for practice settings in rural areas, which may help to incentivize physicians that practice in those areas. For this reason, staff is suggesting that the board take a neutral position on this bill, but I would need a motion.
So moved.
Have a second? Any discussion from the board? Any comments from the audience? Any comments on the phone?
Comments.
No comments.
Thank you. Roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Excuse me, Dr. Hawkins?
Yes.
Ms. Lawson? Dr. Kraus?
Yes.
Ms. Pines? Dr. Lewis?
Aye.
Mr. Wormuth?
Aye.
Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye. Motion carries.
Okay, moving on to the next bill, AB 182. This bill would require the Department of Healthcare Services, in consultation with stakeholders as appropriate, to develop, coordinate, implement, and oversee a comprehensive multicultural public awareness campaign to be known as the Heroin and Opioid Public Education Program, or HOPE, to combat the growing heroin and opioid medication epidemic in California. This bill would require the HOPE program to provide for the coordinated and widespread public dissemination of individual case stories and other generalized information using appropriate types of media, including new technologies and media, print media, television and radio, internet and social media. In disseminating this information, the HOPE program shall employ a variety of complementary educational themes and messages that shall be tailored to appeal to different target audiences. This bill would require DHCS to submit a report to the governor and the legislature on at least an annual basis. that summarizes the actions undertaken by DHCS to implement this bill and include an assessment of the effectiveness of the HOPE program. The report shall provide any recommendations for legislative or executive action that may be necessary to facilitate the ongoing success of the HOPE program. This bill will increase awareness and provide education to help prevent heroin use and opioid medication abuse, and furthers the board's mission of consumer protection. Board staff recommends that the board support this bill. I need a motion.
Okay, any discussion from the board? Yeah, Dr. Bishop.
I certainly agree in principle with this bill, but I'm an old guy and I've seen this kind of stuff kind of come and go. Do we have evidence that this sort of outreach actually has an effect? Is there any other studies been done, or I'm just curious? I mean, because when I was a kid, they had a lot of scare tactics on TV about this is your brain on drugs. I'm not sure if it made a difference. I'm just curious. We just if we're going to do this, we want to be sure that we look at what happened in the past, what did and did not work, and tailor it, because we would want to. This is critical. We want to just make sure that if we do this, make it absolutely good.
I don't know if there's actual studies related to getting the outreach out and if it makes people not abuse opioid medications or not, but I think from staff's point of view, as we were looking at like any information we can get out there. So some of the work that DHCS or the CDPH work group is doing, but it's actually deliverables that are required, and so that's why we thought it was something that would be good to support.
Yeah, when I see suspense in appropriations, I know what the
Right.
cause is. It's the money.
Yeah.
So, anyway, any comments from the public? Comments on the phone?
No comments.
Thank you. Roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop? Aye. Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Wormuth? Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye.
Thank you.
Motion passes. Next one.
Okay.
Jennifer.
Next bill, AB 505. This bill would prohibit the board from entering into a stipulation for disciplinary action if the stipulation places a licensee on probation and the operative accusation includes a felony conviction involving harm to a patient's safety or health, drug or alcohol abuse, or a sexual act or sexual exploitation. Any settlement recommendation, okay, so basically this would prohibit us from going, any case that fell under those definitions would have to go to a full hearing, so settlement wouldn't be an option. As many of you here probably know, any settlement recommendation stipulated by the board must provide an appropriate level of public protection and rehabilitation. Settling cases by stipulations that are agreed to by both sides facilitates consumer protection by rehabilitating the physician in a more expeditious manner, and by entering into a stipulation, it puts the individual on probation on restriction sooner, and the public is able to see the action taken by the board more timely than if the matter went to hearing. In addition, the board may get more terms and conditions through the settlement process than would have been achieved if the matter went to hearing. If the board is required to go to hearing for certain cases, there will be a significant fiscal impact to the board, and we're estimating over $3 million. And it will also significantly increase the board's enforcement timelines, which is something that we were trying to decrease. This bill will not enhance consumer protection, as it will result in physicians practicing longer with no monitoring or restrictions by the board. So taking that into account, board staff is suggesting that the board oppose this bill. So we need a motion.
I so move. We have a second. Discussion from the board. Okay. Comments from the audience. Comments on the phone?
Yes, we have a comment from Alicia Sanchez with California Medical Association. Please go ahead.
Good afternoon, Alicia Sanchez with the California Medical Association. We are the sponsor of AB 505 and believe that it enhances, or that the bill enhances the integrity of the profession by ensuring that serious allegations are fully investigated and that probation can be offered only after there's a finding of fact. Because it is important that these serious allegations, be treated in a manner that ensures the public trust in the disciplinary process and maintains due process for physicians at the same time, and would ask that the board establish a neutral position on the bill. Thank you.
Thank you, Alicia. Any other phone comments?
No further comments on the phones.
Thank you. Let me make sure that, any comments from the board before we go to the roll call? Okay, roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Wormuth? Ms. Wright? Dr. Yip? Dr. Gonadev?
Aye.
Thank you.
Motion carries. Go ahead.
Okay, next bill is AB 715 Wood. This bill would require the California Department of Public Health to convene a work group review to review existing prescription guidelines, including but not limited to the guidelines developed by the Centers for Disease Control and the Medical Board, and develop a recommended statewide guideline addressing best practices for prescribing opioid pain relievers for instances of acute short-term pain. In developing the statewide guideline, the work group may consider, among other things, evidence-based, peer-reviewed research, lessons learned from demonstration pilot projects, or other policies that have been successful in reducing opioid use and abuse. The guidelines shall include, but not be limited to, the appropriateness of limiting initial prescription duration and the appropriateness of a differing prescribing protocol for individuals under 21 years of age. This bill would require CDPH to submit a report to the legislature on or before March 1st, 2019, which shall contain the work group's conclusions and the required recommendations. This bill would sunset the work group on January 1st, 2020. Although the board has already drafted guidelines on this issue through a very extensive process that included stakeholder and expert input, a third-party review of all existing guidelines may allow for additional input and updates for state guidelines. So board staff recommends that the board take a neutral position on this bill. I need a motion.
Second.
Discussion. Dr. Bishop. Oh, Dr. Bishop and then Dr. Lewis. Go ahead, Dr.
Jennifer, is this the bill that initially said that it would prevent any prescriptions for oxycodone to people under 21?
No, that's another bill. There's a lot of bill on preventing
Yeah,
opioid use
yeah.
and misuse this year. So
Okay.
this bill is basically just a third level review of like, okay, you
Sure.
have these CDC, you have ours.
Okay.
What's the best one to
Okay.
use as the state
Okay, great.
guidelines?
So we will, as this bill moves along, we'll have another opportunity to see what they're recommending and what they're doing, or no?
Yeah, so basically the bill just starts this work group. So hopefully we'll be a active participant in the work group and
Okay.
we'd have some input on the process.
Thank you very much.
Dr. Lewis.
Your reason for recommending neutral is because it's so early in the stage that you're not yet ready to support?
Well, I mean, we could definitely support, but I mean, we do have our own guidelines out there that we kind of went through this process for. So this is kind of saying, okay, let's look at CDC, let's look at ours, and let's develop something different than what we've done. So because we've done some work on this issue, I didn't know if we wanted to, I mean, we can support this bill, but it might be, the guidelines might be different than the guidelines that we've actually already done, so.
My comment is that we did put extensive work on this, and even the legislators told us that our guidelines are light years better than what is in CDC, so I'm not sure what it will add. That's why I think right now she's recommending neutral. That's what I gather. And thank you, Dr. Bishop, doing all that work. Thank you.
Okay, so I'm
Okay,
suggesting.
any other comments from the board members?
It's important that we do stay neutral on this at this time, and I appreciate the idea of this work group, because probably at least 2-3 times a week, physicians are really confused and are asking for guidance. And the one comment that I would make that we see on a daily basis, it's not just the opioids and how many milligram morphine equivalents a day, is it high? It's also the other substances that are prescribed with them, such as, benzodiazepines and other things. And that's where the things become very difficult and challenging. So I do support a neutral position.
Okay. Comments from the audience? Any comments on the phone?
Comment.
No comments.
Okay, so roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop? Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Wormuth? Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye.
Thank you.
Motion carries. Jennifer?
Okay, next bill, AB 845 would allow a physician to prescribe and a pharmacist to dispense cannabidiol, or we're going to call it CBD, if it is removed from Schedule 1 of the Federal Controlled Substances Act and placed on a schedule other than Schedule 1, or if a product composed of CBD is approved by the Federal Food and Drug Administration and either placed on a schedule of the Act other than Schedule 1 or is exempted from the Act. If a physician and pharmacist prescribes and dispenses CBD in accordance with federal law, they shall be deemed to be in compliance with the state law. This bill would state that upon effective date of one of the federal changes specified in this bill, the prescription, furnishing, dispensing, possession, or use of a product composed of CBD in accordance with federal law is for a legitimate medical purpose and is authorized pursuant to state law. This bill is an urgency statute and would take effect immediately upon signing the law. According to the author, the purpose of this bill is to ensure Californians with uncontrolled seizures will have continued access to FDA-approved epilepsy treatments derived from CBD. This bill wouldn't become effect until any of those federal changes, so it's basically just conforming, if that happens in federal law, it's basically conforming that state law when that happens, and to allow those treatments authorized by the federal government in the future. So board staff is suggesting the board take a neutral position on this bill.
So move.
Have a second?
Second.
Any discussion? It is a difficult issue. I know one ER doc whose daughter, the only thing which worked on her was what you mentioned, CBD. And it's when you see little kids suffering, it gets to you. But unfortunate thing is we still don't know what the dose is. You don't know what the strength is. You don't know how to follow. So we have ways to go. All right, comments from the audience? Comments on the phone?
No comments.
Okay, thank you. Roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop? Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Wormuth?
Aye.
Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye, motion carries. Thanks.
Okay, and the next bill, AB 893, would authorize until January 1st, 2022, Pioneers Memorial Healthcare District to employ physicians in charge for professional services. The district can only employ physicians if the medical staff concurs by an affirmative vote that employing physicians is in the best interest of the community served by the district, and if the district does not interfere with, control, or otherwise direct the professional judgment of a physician in a manner prohibited by existing law. This bill would require the district to submit reports to OSHPD on an annual basis. The district includes one hospital, Pioneers Memorial Hospital, and one health center in Calexico. This bill would expand on AB 2024 from last year and allow the district, which is a rural healthcare district, to better recruit and employ physicians in order to assure physician retention in a rural setting. The board has always believed that the ban on the corporate practice of medicine provides a very important protection for patients and physicians from inappropriate intrusions into the practice of medicine. That being said, this bill only applies to one hospital and one health center, and this bill would help this hospital to recruit and retain physicians. In addition, this bill is a pilot program that will be evaluated, and the bill makes it clear that the district must not interfere with, control, or otherwise direct the professional judgment of physician. This bill is modeled after AB 2024 from last year, in which the board took a neutral position. So as such, staff is recommending the board also take a neutral position on this bill.
Do we have a motion?
So move.
Second.
Okay, any discussion? Okay, any comments from the audience? Comments on the phone?
Comments.
Thank you. Roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop? Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Wormuth?
Aye.
Ms. Wright? Dr. Yip? Dr. Gonadev?
Aye, motion carries.
Okay, next
Keep
bill,
going,
AB
Jennifer. Actually, you're talking slow today,
I'm
so
trying.
it's good.
Okay, the next bill you should have got an updated analysis on. This is AB 1048 Arambula. This bill would authorize a pharmacist to dispense a Schedule II controlled substance including opioids, as a partial fill if requested by the patient or prescriber. This bill would specify that subsequent fills, until the original prescription is completely dispensed, shall occur at the pharmacy where the original prescription was partially filled. This bill would require the full prescription to be dispensed not more than 30 days after the first partial fill. 31 days after the initial partial fill, the prescription shall expire, and no more of the drug shall be dispensed without a subsequent prescription. This bill would require the pharmacist to record in the state prescription drug monitoring program only the actual amounts of the drug dispensed. This bill would require the pharmacist to notify the prescriber that the prescription was partially filled and the amount of the drug that was dispensed as specified. This bill would also remove the requirement that pain be assessed at the same time as vital signs and would instead include pain as an item to be assessed, which shall be noted in the patient's chart. This bill will increase consumer protection by allowing for partial fill of opioids, which will likely reduce the supply of opioids that could potentially be misused or diverted. And it takes reasonable steps to address the opioid epidemic. Board staff recommends that the board support this bill. I need a motion.
Okay. Do we have a motion? Do we have a second?
I'll second.
Okay, any discussion from the board? Yes, sir, Dr. Hawkins.
Do you know if there's been any input from the pharmacy board or the pharmacy association regarding this? Seems a potential to really increase the amount of work they have to do in traffic and.
Yeah, at the time that I got the analysis, they hadn't weighed in yet, but I could find out, but.
So pharmacy board, I think they're having a meeting next week, so they may not have taken a position on this yet. I don't know for sure, but I know their meeting's not till next week.
Dr. Bishop.
I see in your original analysis, it says that this bill would prohibit health facilities from in any way conditioning or basing executive compensation, ... Has that not been removed?
Taken out, yeah.
Thank you.
In the most recent amendment.
So actually, this might cut down the opioid sitting at home in a bottle. I mean, that's the way I look at it, because many times somebody prescribes for severe pain from a broken bone, gone after 2 days, but you have a 30-day prescription sitting there. So I think it's a good idea. So
I would agree with that. I just wondered what the pharmacists are going to do with the traffic, running in and out of the pharmacy.
No. Thank you. Comments from the audience? Any comments on the phone?
Yes, we have a comment from Alicia Sanchez with California Medical Association. Please go ahead.
Yes, Alicia Sanchez, California Medical Association. We're the sponsors of AB 1048 and very much appreciate the staff analysis and recommendation for support. And Dr. Gonadev, we agree that the idea is to reduce the supply but still maintain the flexibility for the provider and the patient to ensure that there is appropriate care. As we know, the vast majority of people who misuse opioids for non-medical purposes are getting them not directly from a prescription but from supply that's out there in medicine cabinets, and so we think that this would be a significant improvement in that issue, and ask for your support. Thank you.
Thank you. Any other comments on the phone?
We have a comment from Khadija Langi, President of Golden State Medical Association. Please go ahead.
Thank you. This is Dr. Khadija Lang again. I wanted to know if I could get clarification. This bill would allow the pharmacy to give partial fulfillment of a prescription that the physician writes, and then the patient has 30 days to come back and get the completion of it. Is there a reason why they would not be initially filling the full amount other than have it on supply at hand?
Jennifer, yeah.
So basically, it would allow for the partial fill, but it would have to be requested by the physician or the prescriber or the patient. So they just wouldn't automatically partial fill. It'd have to be a request to do so. So it's not a requirement. It's more of an authorization for the pharmacy.
Okay, thank you very much. I think it's a good idea. I would support it as well.
Any other comments on the telephone?
No further comments.
Thank you. Any comments from the board now? Again. Not roll call, please.
Dr. Bolot? Aye. Dr. Bishop? Aye. Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Warmoth?
Aye.
Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye, motion carries.
Okay,
one.
next bill, AB 1204 Mays. This bill would allow a physician to prescribe a 1-month supply of a life-saving medication as defined to a patient to be stored for the use of that patient in case of a natural disaster or other emergency. This bill would specify that a life-saving medication does not include medications that are primarily prescribed to relieve pain. According to the author's office, this bill is a district bill, and the purpose is to ensure that once a year, a doctor can prescribe a life-saving medication over and above what is normally prescribed, so that patients can store that medication at home in case of a natural disaster or other emergency. And the example they gave me is like a bridge or something goes down, and they live in a really rural area, and something happens, they don't have extra medication on hand, so this was brought to their attention. So it's basically over and above. Ensuring that patients have access is important to these life-saving medications. The bill isn't clearly written that it's over and above the normal prescription. There needs to be some technical amendments to kind of have the bill, actually look like what they're trying to do. So they seem really open to amendments. Staff thinks that, it should make it clear, and also it should really state in there that, that should prohibit controlled substances, and so it says that it shouldn't be used for that, but I think there needs to be some stronger language in there. So board staff would suggest that the board be neutral if these amendments are made, so the technical amendments to actually reflect what the bill is, what they're trying to do, and then to really put a prohibition on controlled substances.
We have a motion?
Also move.
Dr. Lewis, yes, you have a second.
Second.
Okay. Any discussion? Ron?
I'm just a little confused about the reason for this bill, and I see there's going to be a lot of confusion with third-party payers, extra prescriptions. They've already got their 1-month supply. They're going to get another month's supply.
So how they explain to me, like on January 1st of every year, these patients should be able to go to their doctor and say, okay, I have this heart medication. I want to get my 1-month supply in case something happens and I cannot get on the road and I can't get my medication. I want this one-time thing where I can have this extra month supply. I don't know how the payer situation, and this bill isn't clear that it's in addition to, it just says a person can get a 1-month supply, and I was like, what's that difference from existing law? A person can get a 1-month supply now, but, so that's their intent. So there just needs to be some technical amendments to ensure what they're trying to do is what the bill actually does.
And I don't think for the billing that it was actually changed, because they wouldn't fill that unless their current prescription was now gone, and so they would be going in for their normal one anyway. It's just that they don't have to get to the doctor, right, to get that, the prescription
I think
can
they would
fill
it, and it would be in their medicine cabinet. That's
Oh,
what
I
they're
see what
trying
you're
to
saying.
do.
They'd have
Yeah.
to.
It's in my medicine cabinet, and I have it if the
I
road
paid
goes
for
down.
it, and
Okay, Dr. Bollard and then Dr. Kraus.
No, I really don't want to underestimate this issue for patients and then subsequently the doctors and their staff, because somebody said I can get an extra month, and then the PBM says there's a quantity limit, and particularly I'm concerned about under-resourced populations that may have the Medi-Cal fee-for-service and the managed care and so on, Medicare patients. So I think it's a great concept, but I'm concerned about the how. I understand the why, but it's the how that's concerning.
Dr. Kraus?
Assuming that patients aren't instructed as to how to rotate their stock, I imagine there'll be a lot of extra 1-month supplies that go out of date that could be harmful to patients if taken beyond the expiration date, or could be disposed of in an undesirable manner.
Okay. Dr. Bishop, and
Yes,
then
I
Mr.
wanted to second what Dr. Kraus said. I was going to say also, people, for whatever reason, gosh knows, could stockpile this, or potentially even sell it. Gosh knows what people do out there. So I would like to see some facilities, so if the patient does receive that 1-month supply, their ordering physician should have some access to seeing what they've done with this over the years. So they either don't write it again if the medicine doesn't run out, or they dispose of it in the physician's office.
Mr. Warmoth.
My question isn't really about the merits of the bill. It's kind of a technical question to staff. What's the difference between neutral if amended and oppose unless amended?
Well, neutral if amended is basically like, we're okay with it, but we need these amendments. Oppose is like, unless you make this amendment, we're opposed, and we're gonna, it's a stronger position, basically, that you don't like it as much as you would if the neutral if amended.
Yeah, I mean, the way this bill is structured, quote unquote, for the benefit of the patient, it's difficult for us to just say oppose. Hey, if there is a San Andreas Ghost and there California is an island, it might work. So, but anyway, any other comments from, Dr. Cross?
I wonder if this could be replaced by a bill that outlaws disasters.
It probably could be, if we could only have control of that, right?
I think we're losing it, so any other comments? Comments from the audience? Comments on the phone?
No comment.
Thank you. Roll call, please, Lisa.
Dr. Bolat?
Aye.
Dr. Bishop? Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Warmoth? Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye.
Thank
Motion carries. Next one.
Okay, next bill, AB 1340, Mainshine, would require the board to consider including a course in integrating mental and physical health care in primary care settings, especially as it pertains to early identification of mental health issues in children and young adults and their appropriate care and treatment. The sponsor has believed that's imperative that all medical professionals are trained in recognizing the early signs of mental health issues in children and young adults. Although the board has historically opposed mandated CME, this bill would not mandate CME for physicians. It only requires the board to consider this course. The board does not track employment information for physicians, so the board would not know which physicians practice in primary care settings. However, if the board decides that it is important to get out information to physicians on this particular type of CME, it could include an article in its newsletter or put information out on its website. We've done this in the past for other similar bills that just allow us to consider a certain type of CME. We've done it, I think it was for geriatric care in emergency settings. We did an article in our newsletter, so we could do something similar to this. This bill is sponsored by the Steinberg Institute, and I'm suggesting that we take a neutral position.
Second.
Okay, any comments from the board? Dr. Bishop?
I'm sorry, I must have had too much coffee at lunch.
Okay.
With all due respect to the legislators, I don't understand the purpose of putting something in legislation that says you may do this. I can understand if it's a big issue, I can understand you might want to say, like before, let us have a task force, which then increases awareness. But to put something in legislation says, well, you can do this if you want to, but you don't have to. I don't see the purpose of that, honestly. Maybe I'm ignorant.
It's usually because we say if it's mandated CME, we would likely oppose it. So this is their less, we don't want the board to oppose it, but we'd like you to consider it. And I think they would like to work with us on some sort of newsletter article or some kind of information or education out to physicians, so.
And if you look at our sectional law for CME, there's probably about 6 to 10 of the may do this under there.
Okay, any other comments from the board? Okay, comments from the audience? Comments on the phone?
No comment.
Thank you. Roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop? Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Warmoth? Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye. Motion carries. Next one.
Okay, AB 1368 Calderon. This bill would authorize a physician to designate a physician assistant, PA, or a nurse practitioner, NP, to sign any authorization form required for benefits and services under the Medi-Cal program, provided that the physician and the PA or NP are each enrolled as Medi-Cal providers. Allowing PAs and NPs to sign off on authorization forms for Medi-Cal seems reasonable, as they are both already recognized as primary care providers in Medi-Cal. This bill would only allow PAs or NPs to sign off on authorization forms if their physician supervisor has designated them to do so. This may prevent delays in access to care for Medi-Cal patients and will not compromise consumer protection. Board staff suggests the board take a neutral position on this bill. Need a motion.
Okay, do we have a motion?
So moved.
Second.
Okay, any discussion? Dr. Hawkins?
Not sure I understand the purpose of the bill.
So basically, right now, it has to be a physician that signs off on certain medical forms, like the treatment authorization forms, and this bill would allow an NP, a nurse practitioner, or a physician assistant to also sign off on those forms. They're all Medi-Cal providers right now, and the physician would have to designate them to sign off on those forms, but it just basically, sometimes it's hard, from the background sheet, sometimes it's hard to get a physician to sign those forms in a timely manner, so it would allow an NP or PA to sign off on those forms. It's
So-
kind of, yeah, they have to
Yeah,
designate
it's a
them.
streamlining process, it
Yeah.
looks like, more than anything else. Ron?
More of a technical.
But Jennifer, the NP does not need to have, to be designated. It says
The
in the
language
last paragraph.
the language still reads like that. So originally, this bill was just a PA bill, and then at committee's request, they added nurse practitioners. The language still does read that they'd have to designate them.
Okay, so this is an update. This last paragraph doesn't say that, so. It says, this will allow PAs to sign off if their physician supervisor designated them to do so. Then I don't see the NP part.
Yeah, it's an updated one. It should be in your updated packet.
It should be in
yeah.
this packet.
So they
Okay.
just, NPs just got added as part of the committee, asked them to take those amendments, so.
Okay, thank you.
The language just reads the same, it just added NPs in there.
Any other comments from the board? Any comments from the audience? Comments on the phone?
Comment.
Okay, roll call, please.
Dr. Bolot?
Aye.
Dr. Bishop? Aye. Dr. Hawkins?
Yes.
Dr. Kraus?
Aye.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Wormuth? Ms. Wright?
Yes.
Dr. Yip? Dr. Bonadib?
Aye. Motion carries. Next
Okay.
one, go ahead.
Next bill, AB 1512 McCarty. This bill would create the Opioid Addiction Prevention and Rehabilitation Act, which would, on and after January 1st, 2018, impose a tax upon the distribution of opioids by every person, including but not limited to, a manufacturer or wholesaler that makes the first sale of opioids in California, where the sale is for the purpose of resale in the regular course of business at the rate of 1 cent per milligram of active opioid ingredient. Now, on your analyses, it's a little outdated because I just checked yesterday and it got amended, so I wrote it in here for my notes. So before, it would have created a fund, and Department of Healthcare Services would have allocated monies from the fund to counties to provide addiction prevention and rehabilitation programs. So yesterday, the bill was amended to delete that language regarding the fund, and instead state that it is the intent of the legislature to enact legislation that would provide for distribution of the funds for addiction prevention and rehabilitation programs. So it's taking CDPH out. There must have been an issue with CDPH being the one to do that function, and so, I mean, I still think that, my suggestion is that we should support this because it does fund the people that actually manufacture the opioids, and but it's a little not as clear on how those monies are going to get, who's going to actually put those monies out, but I think the intent is still the same, so that's a little change from yesterday. So I'm suggesting that we support the bill.
Also move the support.
Second.
Some discussion? Yes.
Actually, I have some discussion.
Board.
That's quite all right.
Comments from members?
I'm a member of the public as well.
Yes.
So this is then placing a surcharge on the manufacturers or wholesalers. Is there anything that prevents them, I'm a negative person, but prevents them from passing that along to the consumer? So that essentially becomes an additional tax on the consumer
So it's on the first sale of the opioids where the purpose is of resale, so it's taxing the first person, not the person that's actually selling it, I guess, to the consumer. It could be to the consumer.
It's just the point is the pharmacy does that, then they just increase their fees.
Yeah, I mean,
So the
I think
the consumer gets the tax, and it's not that much, but for someone on low income, on chronic pain medication, it could add up.
Yeah, I think they were trying to actually, and I know that in the past our board has said, like, we need to get the pharmaceutical companies and stuff involved, and they need to be helping out with this problem too, so, this is a way that they're trying to do that. I don't know if it can guarantee that nothing will get passed on to the consumer.
That's exactly my concern. I'm a little surprised that we would think about supporting something that involves a tax. And so, I'm not real keen on that. And as Dr. Bishop said, what in here would prevent them from passing along that 1 cent down the chain?
Yeah,
And
like
there's
I said,
nothing
that's
in
the reason why I suggested support, because in the past, the board's been like, hey, the manufacturers and wholesalers need to help with this problem too, and this bill is a way for them to do that, but we don't have to support it.
If you do a neutral, what's the problem with doing the neutral for now?
We could definitely do a neutral. It's just kind of a less like, we don't have an issue with it, we don't really support it, we don't really oppose it. So that's just kind of what a neutral position
I might suggest a friendly amendment then, that would be support if amended, clearly that the amendment would suggest that we don't want this to be passed along to the consumer.
That's a good suggestion, because that means we support it, but there's something, we having a problem with some of the parts of it.
Okay.
Yeah.
Okay, so we have amended motion,
Second.
Yeah,
Okay.
I made it, so.
even though we're in la la land to think that any manufacturer doesn't pass on the thing to the
Right.
consumer, but it's okay, we all come from la la land anyway. Any other comments? Okay, any comments from the audience?
No comments.
That's the phone. Okay, good, you're past me already, that's super. Okay, roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Warmoth?
Aye.
Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye, motion passes. Next one, Jennifer.
Okay, next bill, AB 1560 Friedman. This bill would amend existing law which limits the number of nurse practitioners who are furnishing or ordering drugs that may be supervised by a physician to 4. So right now, currently, the law is a physician can only supervise 4 NPs. This totally deletes the cap, so there's no cap. Allowing physicians to have no limits could be problematic, as it may lead to physicians supervising too many nurse practitioners at one time. It may result in consumer harm due to lack of supervision. So if the cap were to be removed, it may lead to less physician involvement and oversight. So the board staff is suggesting that the board oppose this bill unless it's amended to include a reasonable cap on the number of nurse practitioners a physician can supervise.
I so move that.
Okay, any discussion? Okay, any comments from the audience?
Comments?
Comments on the phone?
Comments?
Okay, thank you. Roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Dr., who did I miss? Dr. Hawkins?
Yes.
Dr. Kraus, yes.
Yes.
Sorry, Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Warmoth?
Aye.
Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye,
Thank you.
motion carries. Next one.
Okay, next bill, AB 1612. This bill is similar to bills in the past. It removes physician supervision for certified nurse midwives. But in the past, the bill actually had parameters on what kind of services could be provided and what kind of patients CNMs could take. This bill basically just removes physician supervision. There's no parameters, as you may remember when the licensed midwife bill went through. There was certain parameters on what types of patients a licensed midwife could take, when there had to be a physician consultation exam. We supported that bill because it was really clear and restricted on what types of patients they could accept and the required physician consultations. High-risk patients cannot be accepted by licensed midwives. This bill doesn't put any of those parameters on certified nurse midwives. They could accept all patients. There's no clear limits. there's basically no defined informed consent or defined referral to a physician. And so, board staff is recommending that the board oppose this bill unless it's amended to address, to be more similar to licensed midwife bill and have clear limits and parameters on what type of patients, a certified nurse midwife could accept.
Okay,
Okay, I'll make a motion to accept your
motion made. Any second?
proposal. on this one.
Second.
Okay, Dr. Cross, second. Any comments by the board? I have a couple audience comments. First one is Shannon Smith Crawley.
Thank you. Shannon Smith Crowley, representing the American Congress of Obstetricians and Gynecologists. We were sponsors of AB 1308, and even though it is imperfect, as we will talk about tomorrow, it has made tremendous improvements in out-of-hospital care, especially at the pinch point, the really delicate point of when a midwife transfers somebody in a crisis situation into a hospital. The physicians report significantly improved relationships and outcomes. The midwives have said if they have resistance at the hospital, which is understandable, you're going to get some people that resist, they use the magic words, "I'm legally required to talk to you and do this transfer." And that opens the doors. So that has made significant improvements. That is not in this bill. Any of the other protections for out-of-hospital are not in this bill. The other thing is, ACOG policy, and I think is consistent with what the board is and what CMA is that while we support independent practice of certified nurse midwives, it's when it is in parity with physicians. That means if they're going to stand in the shoes of physicians, all of the laws apply equally, so including the corporate bar in the practice of medicine and anti-kickback. So we would actually ask that the board request those amendments as well.
Thank you, Dr. Carl. Next one is Sarah Davis, California Association of Licensed Midwives.
Good afternoon, it's Sarah Davis. I'm a licensed midwife in San Diego as well. California Association of Licensed Midwives represents California's licensed midwives, not the nurse midwives that are being addressed in this bill. And we do support the bill, AB 1612, and we do encourage the board to, if not at this particular juncture, later on, do support this process. We support our certified nurse midwife colleagues in their ability to provide evidence-based autonomous care to the extent of their training, and they do so in all states except 6. And we do know that this bill, if enacted, would create 2 different sets of requirements for licensed midwives and certified nurse midwives. And while that might not be an ideal in La Land, here in the real world, we've had different political contexts that produce 2 different bills, and it's fine with us if it's different. It happens.
Thank you, Ms. Davis. Any other comments from the audience? Any comments on the phone?
From Alicia Sanchez with California Medical Association, please go ahead.
Thank you. Alicia Sanchez, representing the California Medical Association. We would align with our colleagues at ACOG in wanting to see protection as afforded by the licensed midwife construct in terms of out-of-hospital births and transfers and consent. We'd also like to point out that the bill as drafted includes a requirement for standardized procedures and protocols for furnishing medications, which we believe would create confusion for patients and increase liability for physicians, and really is basically unworkable. Without having had the benefit of an analysis to look at, which I think it was missing in the packet that's online, we would ask for you to oppose AB 1612.
Thank you. Any other comments on the phone?
No comments.
Thank you. So we have a motion on the floor. Recommendation is oppose unless amended. Any other comments from the board? If not, a roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop? Aye. Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Wormuth? Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye, motion carries.
Okay, next
Jennifer.
bill, AB 1650 Mainshine. This bill would create the Community Paramedic Program in the Emergency Medical Services Authority. This bill would sunset the program on January 1st, 2022, so it's a pilot program. This bill would allow the Community Paramedic Program to authorize a local emergency medical services agency that opts to participate in the program to provide any of the following services: post-discharge follow-up services for targeted and eligible patients recently discharged from a hospital, directly observed therapy for eligible patients undergoing tuberculosis treatment in partnership with the County Public Health Department, hospice rapid response service for eligible and enrolled patients to administer comfort care, coordinate services with the hospice nurse, and as appropriate, avoid patient transport to an acute care hospital emergency department, and case management services and linkage to non-emergency services for frequent EMS system users. This bill would require IMSA to develop criteria that qualifies local community paramedic services to participate in the program, which must include minimum training and certification requirements. This bill would require IMSA to provide OSHPD with an annual report regarding all local community paramedic programs that would include program effectiveness, cost savings, and patient safety, and including details regarding adverse patient outcomes. OSHPD would be required to report this, to publish a report on its website. So just for a little history, beginning in 2014, 13 community paramedicine pilot projects began in California, testing 6 concepts as part of the Health Workforce Pilot Program. These HWPP pilot projects are coordinated through OSHPD, and this bill would basically authorize 4 of those original 6 concepts. So at that time, back in 2014, Kim and I worked with a board member who is a physician, who is Dr. Kraus, and we provided input to OSHPD on this pilot project. So, and we raised patient safety concerns. So one of these concerns being that persons recently discharged from the hospital should be seen by their primary care physician for follow-up care, and that any additional training that would be required would not be sufficient enough to teach paramedics the basics of disease management or how to diagnose and treat medical conditions. And the other concern raised was that pilot project did not specifically delineate what services would be allowed to be performed by the community paramedics as part of their post-discharge follow-up services. So all these same issues are still true for this bill. And the board staff believes this could have a negative impact on consumer protection, and so board staff is recommending the board take an opposed position on this bill.
Okay, do we have a motion to oppose?
I'll move to oppose the bill.
Second.
Okay, any comment? Dr. Cross?
I haven't followed and studied the issue closely on a continuing basis, but when I was looking at it 2 years ago, at one of the meetings we attended, I came across a flyer from an ambulance corporation promoting this as a method of increasing revenue for the ambulance business. So I'm concerned that this may arise out of a economic desire from the ambulance industry rather than out of a desire to improve public health and well-being. I'm further concerned that creating this barefoot doctor regime, so to speak, not under the direct supervision of physicians, can end up being very harmful to the community.
Any other comments? Dr. Bishop?
Actually, I think Dr. Balat was first.
Oh, Dr. Bola, I'm sorry, go ahead.
No problem. This is a very interesting bill that has come forth here, and the bullets about the direct observed therapy for patients undergoing TB and hospice and case management. I think I just want to bring it, and I know that I'm preaching to the choir here, but in so many health systems, very large, well-respected health systems, many times we're using administrative people to do the work of physicians. I just want to say that I think there is some merit to some of this, but I do agree with my colleague who studied this more deeply than I did, Dr. Kraus, in 2014. But as things are evolving, those first responders, these aren't first responders, these aren't 911, these are ambulance companies, I take it, or paramedics, the idea that many of these patients don't have access to primary care, and it's a bunch of telephone calls and homeless people being tracked down, that I think I understand where they were coming from. I would hope that in some way we could be continuing to look at the extending the physician workforce in meaningful ways to increase access.
Thank you. Dr. Bishop?
Having spoken with a number of fire personnel who are paramedics and do a lot of these calls, there is a lot of frustration that they're called out on things that the patients don't know, but it's not an emergency, and they're taken away from potential places where they are needed for emergency medical transport and care. So I agree that I think it would be wonderful if there was a secondary system that could take care of this sort of a thing, so patients would not call the primary services when that's not necessary. I'm just not sure that this is the best way to go about it. Putting it in the private sector makes me a little bit concerned. I would hope perhaps that the legislature might work with our primary EMS services to develop a system by which we could provide the proper level 1 and level 2 out-of-hospital primary care like this.
Okay. Any other comments? Any comments from the audience? Comments on the phone?
None.
Okay. Motion is made and seconded. Roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop? Aye. Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Wormuth?
Aye.
Ms. Wright? Dr. Yip? Dr. Gonadev?
Aye. Motion carries. Jennifer?
Okay, next bill, SB 241 Monning. So we've made it to the SB side, that's good. This bill would conform existing patient access to health records law to HIPAA. It would clarify that a patient or patient representative is entitled to a paper or electronic copy of their record. So before it was just paper. This bill would require a healthcare provider, if the requested patient records are made electronically, and if the patient or their representative requests an electronic copy, to provide them in an electronic format requested if they're readily producible in that format. This bill would specify that a healthcare provider can charge a patient or their representative and would allow a healthcare provider to impose a reasonable cost-based fee for providing that paper or electronic copy, provided the fee only includes specified costs, and that's a little more detailed than what the existing law is now. This bill would conform existing California law to federal law to allow for electronic requests, and it would allow patients and their representatives to receive electronic copies, and would make it clearer on what the fees that can be imposed. And this bill would help ensure that patients have better access to their medical records. So as such, board staff is suggesting that the board take a support position on this bill. I would need a motion.
Do we have a motion to support?
So moved.
Okay. Second?
Second.
Okay. Any comments? No. Any comments from the audience? Comments on the phone?
No comment.
Thank you. And the roll call,
Question.
please.
Why is it so long?
Why is what so long?
The bill?
Yes.
Why is the bill so long?
Yeah.
I think it's just because it's different areas that they need to amend the law. Yeah, there's a lot of law on patient access to health records. So they're making different changes in different areas, but the ones that I read off to you were the main differences. That's what's in law now.
Okay.
In the end, don't forget, patient actually should own their own medical record. So I think what they're asking is not a lot. But if we are putting physicians at work to do, they can get their costs, so it's fine. Ron?
I think now, isn't it required that physicians provide a portal for patients to access their individual records? I know that when I go to the doctor, I'm always asked to sign up for some.
I don't think that's in statute. I think that's just depending on your health.
Just there.
Yeah.
So regarding this, we can see the problems with different electronic health record systems and trying to get the access, and the patients say, I can't get the access to the records because it's not in the right format.
Yeah.
So I don't know if they've thought of all that, but I mean, it's a good idea in concept. I think the delivery
Right now,
may be a
the law,
problem.
basically, it's only in writing, and so this is just kind of updating it to HIPAA. It says if they're not producible in the format the patient requested, then it has to be the closest format that it
paper.
is producible.
Or back to paper?
Yeah, if they don't
Yeah.
have electronic, yeah, health
Okay.
records.
Yeah, just to give you an answer on you're talking about the meaningful use 2 guidelines from CMS, but that's only to get either a bonus or get a penalty from CMS. It's not a law that you have to do.
Got it.
Okay, so roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop? Dr. Hopkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Ms. Pines? Mr. Wormuth? Ms. Wright?
Yes.
Dr. Yip? Dr. Gonadev?
Aye, motion carries.
Okay, next bill, SB 554 Stone, would allow nurse practitioners and physician assistants to administer or provide buprenorphine to a patient when done in compliance with the provisions of the Federal Comprehensive Addiction Recovery Act, or CARA, as enacted on July 22nd, 2016. So basically, this bill would just conform California law to federal law, which was enacted in 2016, and would allow NPs and PAs to administer buprenorphine as long as they meet the requirements specified in this bill and in federal law. This bill would help to ensure expanded access to buprenorphine, which is used to treat opioid addiction, and this expansion seems reasonable and in line with federal law. And so the board staff is suggesting the board support this bill.
I'll so move the support of the bill.
We have a second? Okay. Any comments? Ron?
This bill was amended prior to this. Can you give us the history? Because there was something else different in this bill than there is now. Regarding the nurse practitioner and their role, was there something that was prior to this?
Let me see here.
They have no supervision, right? They can just administer the buprenorphine on their own?
Well, I mean, nurses are supervised by physicians.
Well, nurse practitioners have to have
Yeah,
a
nurse
loose
practitioners are too. though.
affiliation, but
Yeah, they have physician supervision, but let me see here what was recently changed.
I had read a different version, but, you know.
This is just a gut and amend, so basically, it was a total gut and amend. So what was in there before had to do with, authorizing a nurse practitioner holds a certification from a national, it was a totally different subject. So this buprenorphine, on April 17th, is just a gut and amend, so it's a whole new subject.
It's a whole new
area.
subject.
Yeah.
They took it out and put in a new one.
Yeah, right.
Okay, I saw the older one, that's why. Okay, thank you.
Any other comments? Comments from the audience? Yes.
I just have,
Dr. Bola?
yes, sorry, slow on uptake here. Quick question. So in this bill, it's stating that physician, of course, meets all the requirements, has his or her X waiver. But if the doctor doesn't have the X waiver, then the PA or the NP cannot prescribe?
Let me see. if
That's my
it's-
question,
that's-
because this comes up actually in training institutions where buprenorphine, if you're precepting or overseeing the buprenorphine prescription, you yourself need to have comfort and understanding of the pharmacology and the adverse effects of that drug.
I'm trying to see if it actually talks, because it's talking about what the nurse practitioner, what they have to have, but I'm not sure that it says what they're.
Dr. Boland, am I correct in recalling from a prior life that the use of that drug in many institutions is restricted to only certain personnel that have specified
With an X
training and
waiver.
skill? Yeah.
Yeah, as far as I can tell, it doesn't speak to that. It just says requirement that the NP and PA have to be supervised by or work in collaboration with the licensed physician and surgeon.
So it doesn't.
It doesn't,
state
so I
that.
would like a friendly amendment to that.
Yes.
Okay.
Now, from the standpoint of PAs, theoretically, their delegation of services agreement would then proscribe them from prescribing something like that if their supervising physician did not have the requisite skills. And so, in the case of PAs, I believe that's probably covered. NPs, I'm not so sure.
Right. That's the problem with that bill. I remember something.
So support if amended?
Yeah, we'll move to support if amended.
To include supervising physician as authorized to prescribe, is that what we are looking at?
What's the
With the
waiver
X waiver.
called?
X waiver
It's a certification or
on your DEA.
your DEA, got it.
And I can work with you, Dr. Bullitt, on the amendment if I need more clarification.
Does it also include that the nurse practitioner have the special training that's required?
It does, actually. I can read it through if you want, but it does require the training for the nurse practitioner.
Okay, any other comments? So, comments from the audience? Comments on the phone?
No comments.
Thank you. So we have the amended motion. Can we call for roll call?
Dr. Bolat,
Aye.
Dr. Bishop,
Aye.
Dr. Hawkins,
Yes.
Dr. Kraus,
Yes.
Ms. Lawson.
Yes, sorry.
Thank you. Dr. Lewis.
Aye.
Ms. Pines.
Aye.
Mr. Wormuth.
Aye.
Ms. Wright.
Yes.
Dr. Yip.
Yes.
Dr. Gonadev.
Aye, motion carries.
Okay, next bill, SB 641 Lara. This bill would specify the Department of Justice shall only provide data obtained from cures or the Controlled Substance Utilization Review and Evaluation System to a federal, state, or local law enforcement agency pursuant to a warrant based on probable cause and issued at the request of the law enforcement agency engaged in an open and active criminal investigation regarding prescription drug abuse or diversion of controlled substances involving the individual to whom the requested information pertains. So this bill originally would have restricted regulatory boards' access to cures. It was amended, and now it only affects law enforcement access to cures. It does have a small impact on us because there are a small number of criminal investigations that are performed on behalf of our HQIU investigators on behalf of the board, but that's only approximately 20 a year, so board staff doesn't have any concerns. The author's office did take a technical amendment to specify that it only applies to criminal investigations, so we're not worried about it impacting our administrative regulatory investigations, and so they took our amendment, so board staff is suggesting that we take a neutral position on this bill.
Okay, can we have a motion?
I'll give you a motion.
Second.
Okay, so we got a motion made and seconded. Any discussion?
I have something.
Dr. Bishop?
Say there was a concurrent investigation by both the police, for example, and our board. Would we be restricted from giving them information from our cures search?
You know the answer to that, Kim? Yes?
Did I hear yes?
Yes.
Okay. I wasn't sure. It's a balance between privacy and right to know. So I'm okay with that. So, any audience comment? Any comments on the phone?
Yes, we have a comment from Alicia Sanchez. Please go ahead. Your line is open.
Great, thank you. Alicia Sanchez with the California Medical Society. We are sponsors of SB 641. We have been consistently raising questions about the cures privacy over the many years that we have all been working on cures. And looking at our state statute in relationship to other states' statutes where we are out of alignment in that we don't clearly articulate what privacy looks like for, in particular, government entities. There's a lot of specificity about healthcare providers and their access to the database and the required use and paying for the database, but it's not as clear for government entities. In this case, we looked at how medical records, information in medical records would be treated, and this seeks to align that requirement, the law enforcement requirement, with what is generally required for information in medical records, and we would ask for a support position. Thank you.
Thank you. Any other comments on the phone?
None. There are no further comments.
Okay, so we have a motion made for neutral and seconded. Any other comments from the board? If not, roll call.
Dr. Bolat.
Aye.
Dr. Bishop. Aye. Dr. Hawkins.
Yes.
Dr. Kraus.
Yes.
Ms. Lawson. Dr. Lewis.
Aye.
Ms. Pines. Mr. Wormuth.
Aye.
Ms. Wright. Dr. Yip. Dr. Gonadev.
Aye, motion carries. Next one.
Okay, SB 746, Portantino. This is a reintroduction of a bill from the past. This bill would allow doctors of chiropractic, naturopathic doctors, and nurse practitioners to perform physical examinations for students in interscholastic athletic programs. existing law only allows physician assistants and physicians and surgeons to perform physical examinations for these athletic programs. These sports physicals require review of cardiac, neurologic, and internal organ functioning, which is outside of the chiropractic and naturopathic scope of practice. Last time this bill came across, we took an opposed unless amended position. We thought it might be reasonable for nurse practitioners to do these type of exams, but not for chiropractic and naturopathic doctors. So board staff again is suggesting that we take the same position, opposed unless amended, where it would be okay for nurse practitioners to perform these exams, but not chiropractic or naturopathic doctors.
Okay, do we have a motion?
So moved.
Second?
Second.
Okay, any discussion from the board? Dr. Bishop, you are actually, that caffeine is kicking in.
I know. Well, you know, when we think of these evaluations, they focus here again on musculoskeletal, but as you mentioned, cardiac, and in the young adult, the adolescents as well, one of the most devastating causes of death on the field is an undiagnosed cardiac abnormality, such as IHSS, or HOCM as we call it now. And that could be diagnosed based on a physical exam detecting a murmur that had previously been undetected. So I think if you eliminate that skill, you're really risking severe potential damage for these young athletes.
Thank you, Mike. Any other comments? Any comments from the audience? No, I'll come back, Ron. Any comments on the phone?
No comments.
Thank you. Dr. Lewis?
So can you oppose unless amended, and the only really amendment is to allow nurse practitioners only?
Yeah.
So is it better just to oppose or oppose if amend?
Well, I mean, last time we took the same position and just basically said our letter said we're okay with nurse practitioners
Only.
performing
Yeah.
these, but not the other two. And
Okay,
I mean, they're probably not going to take that amendment, but that's
okay, I'm just curious the difference. Okay.
Okay, any other comments before we go to roll call? Roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop? Aye. Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Aye. Dr. Lewis?
Aye.
Ms. Pines? Aye. Mr. Wormuth? Aye. Ms. Wright?
Abstain.
Dr. Yip? Aye. And Dr. Gonadev?
Aye, motion carries.
okay. Next bill, SB 790 McGuire. This bill would prohibit a manufacturer of a prescribed product or a wholesale distributor of medical devices from offering or giving a gift to a healthcare provider. This bill would prohibit a manufacturer of a prescribed product or an entity on behalf of a manufacturer of a prescribed product from providing a fee, payment, subsidy, or other economic benefit to a healthcare provider in connection with the provider's participation in research. This bill would authorize the Attorney General to bring an action to enforce a violation of these prohibitions and to seek injunctive relief and imposition of a civil penalty for each violation. This bill would define an allowable expenditure and would provide exemptions to the gift prohibitions. This bill would state that it is the intent of the legislature that the requirements and prohibitions in this bill would complement and operate in conjunction with the Federal Physician Payment Sunshine Act. If the Physician Payment Sunshine Act is repealed or becomes inoperative, it's the intent of the legislature to enact similar legislation requiring manufacturers to disclose payments or other transfers of value made to healthcare providers in California. The board's primary mission is consumer protection. This bill would ensure that physicians are not influenced by gifts or economic benefits when deciding what brand of drug to prescribe, but would still allow for some reasonable expenditures. So board staff is suggesting the board take a support position on this bill.
Just a curiosity, Jennifer. It's a federal law. Why do we need a state law?
There's no law that, so this came up when it came to the foster children and prescribing psychotropic medications. There was some articles where they actually tracked what kind of payments physicians took and how that impacted their prescribing. And basically when they called us and they said, what are you gonna do about this? We basically said there's no law that prohibits it, so here's the law.
So the federal government is not enforcing its law, so we have to do it at the state level. Okay, do we have a motion?
You have a motion.
Okay, second?
Second.
Okay, any discussion? Dr. Cross?
There is corruption, but I'm always amused when the government decides to stamp out corruption with a broad paintbrush. And when I go to a meeting where there might be some hors d'oeuvres purchased by a pharmaceutical company, I have to sign a paper, and that ends up being reported under the Sunshine Act. Sometimes I go to national meetings where they have signs up that say, physicians from Maine and Massachusetts are not allowed to eat. And pharmaceutical manufacturers are no longer able to leave a 10-cent fountain pen at my office. And although I think it's important to protect the public, I take umbrage when every physician is painted as corrupted or corruptible by laws of this nature. So if there is evidence that this level of corruption has caused harm to the public, then I believe we should support it. But I'm not sure that the thesis that a physician receiving some value from a pharmaceutical company or a device manufacturer is always bad for the patient. We accept samples in my office. Those samples are distributed to patients, many of whom need them because they are burdened by the cost of purchasing pharmaceuticals. The federal government recently published a study that cited that because physicians receive samples, their study indicates that brand name drugs are prescribed with greater frequency than generics. If that was true, or if it is true, I'm wondering why the government doesn't support the distribution of sampled generics to physicians' offices, because then that would ease the problem. So while I am in favor of supporting this particular bill with the medical board, I think that we all need to be skeptical as to what really serves the public interest. And sometimes it does serve the public interest to allow physicians to receive something of value that they can turn around and pass on to their patients.
Well, and I should say, I didn't read all the allowable expenditures and exemptions, but an allowable expenditure is provision of meals for a healthcare provider that does not exceed $250 per person. I mean, there's like a whole list of, and then you're talking about samples. The prohibitions of the bill don't apply to samples of a prescribed product or reasonable quantity, or samples basically for free distribution to patients. So both those examples aren't prohibited under this, and I can go through if you want me to read the allowable expenditures and the stuff that's prohibited in this bill, but there's actually quite a few of them that they're kind of trying to allow for some of that, like you're saying, but at the same time preventing bigger kinds of gifts.
No, I'm glad you read those things, Jennifer. Otherwise, it is an issue with anytime I go to a meeting, I don't eat. I don't want my name there. It's these are serious issues, but I think this probably looks better than the federal law, where just don't forget that one of the things implied on opioid abuse is actually what the pharmaceutical companies did in promoting opioids, that they're non-addictive drugs. So there are reasons. I think there is a significant thing behind why it came about, but the consequences sometimes are what Dr. Cross mentioned. So, but with that, any other comments? Dr. Bishop.
I presume this to be true, but this would not prevent a physician from acting in a consulting basis. For example, with a medical device manufacturing company who is requesting an input into the use of this device, or for that matter, pharmaceuticals, something, because physicians do a lot of that consulting work, particularly in the academic areas where they're asked to consult on something. And it seems like that could be quite restrictive if that was the case.
It has honorarium payment of the expenses of a healthcare professional who serves on the faculty of an educational medical scientific or policy-making conference or seminar, a research project that contains a systematic investigation designed to develop or contribute to general knowledge and reasonably considered to be of significant interest or value to scientists or healthcare professionals working in a particular field of inquiry. Can include gross compensation, direct salary, expenses, reasonable expenses. Yeah, those are all allowable expenses. And then there's also a whole list of exemptions as well. And they're in the analysis on page 2 and 3. So 2 is the allowable expenditures, and 3 is basically the exemptions.
But as noted, it should be noted that under federal law, all things of value provided to physicians are reported, and that information is available for public access. So we do have the capacity of following the dollar when we see physicians who have high dollar amounts next to their names under the Federal Sunshine Act.
Okay. Any other comments? Public comment from the audience? Any comments on the phone?
We have a comment from Eric Andrus with Citizen. Please go ahead.
I would be curious as to what Dr. Yip feels about this, since he appears on ProPublica's Dollars for Docs website, which shows him raking in $30,842 from the pharmaceutical and medical device industry in 2013-14. $18,524 of that came from the makers of a drug called Rapaflo, and he has a 41% brand name prescribing rate, which they consider very frequent. So it would be interesting if he would weigh in on this.
Doctor, if you don't have to answer that, because it's a public comment period. Mr. Andrus, your comment is taken in. Thank you. Any other comments on the phone?
No, there are no further comments.
Thank you. Roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop? Aye. Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Aye. Dr. Lewis?
Aye.
Ms. Pines? Aye. Mr. Warmoth?
Aye.
Ms. Wright?
Aye.
Dr. Yip? Aye. Dr. Gonadev?
Aye. Motion carries. Now we are at the big kahuna.
It's our last bill with the big bill.
Well, we'll do a little after that. We might have to look
Okay.
at what we didn't look at, but the big bill. Go ahead.
So this is our sunset bill, SB 798. First, I'd briefly like to provide an update on the hearing. So as Dr. Gonadev mentioned on February 27th, Dr. Gonadev, Ms. Pines, and Ms. Kirkmeyer appeared on behalf of the board to testify at our sunset review hearing. They gave a brief summary of the board and its activities and improvements, followed by responses to questions that were specifically requested by the Senate Business Professions Committee and the Assembly Business and Professions Committee. The committees asked for testimony on the vertical enforcement model, data sharing between the board and other state agencies, disparity in enforcement actions, and complaint processing. Testimony was given by Dr. Gonadev and Ms. Pines on these issues, as they were authorized by the board to speak on the behalf of the board regarding sunset. Patient notification of a physician on probation was also an issue that was discussed. Prior to the hearing, the committees had provided a background paper to the board identifying 30 issues for the board. On March 27th, 2017, after review by Dr. Gonadev and Ms. Pines, the board provided a response on all 30 issues. Several of the issues were items the board had raised in its sunset review report. In addition, several of the issues required proposed legislative language, which the board staff provided to the Senate committee staff on March 10th, 2017 and April 4th, 2017. So like I said, SB 798 is the board's sunset bill, and it includes language on a portion of the new issues from the board's 2016 sunset review report, and will also extend the board's sunset date for 4 years until January 1st, 2022. So I can go about this a couple ways. I've bulleted in the analysis what issues of the new issues, which this board has already discussed as part of the sunset report, are included in this bill, or I can start at the issues to talk about what wasn't requested by the board and it's included in this bill. So,
Jennifer, take the easy one first. Let's finish what the board requested and what's in the bill.
okay, so go over what the board requested and what's in the bill?
Yes.
Okay, so the bill includes a language for a 2-year license for all the board's licensees, and it includes technical language to clean up existing law for licensees not under the purview of the board. That's the first one. This bill includes language that would require an applicant to complete 3 years of postgraduate training, and we talked about this a little bit in the licensing committee. The bill includes some exceptions for applicants who have a medical degree from a combined dental and medical degree program. The bill would create a postgraduate training license with specified application requirements that must be obtained within 180 days after enrollment in a postgraduate training program, and would be valid for 90 days until 90 days after the holder has completed 36 months of postgraduate training. Would also delete the requirement for the board to approve international medical schools, and would determine that an international medical school is recognized. They are listed on the World Federation for Medical Education and the Foundation for Advancement of International Medical Education, and Research World Directory of Medical Schools, Joint Directory of the World Directory of Medical Schools. The next one is the bill includes language largely based on what was included in previous legislation and existing law regarding data that surgical clinics are required to report to OSHPD. It would require the accredited outpatient settings to report this information to OSHPD. It would also revise the adverse events that are required to be reported to the board in existing law to only include those that relate to outpatient settings. This bill would amend existing law to allow the board to require more information about the board in a more consumer-friendly manner on notice to consumers postings. And this changes existing law to allow the board to require changes and more information. This bill would allow the board to fine an entity of up to $50,000 per violation for failing to submit an 805.01 report to the board, or $100,000 per violation if it's determined that the failure to report was willful. This bill would require state agencies and hospital accrediting agencies to report to the board any peer review incidents subject to 805 reporting that are found during an inspection of a healthcare facility or clinic. This bill amends existing law regarding the Health Professions Education Foundation to require 2 members to be appointed by the board, as was previously required. Let's see. The board recommended in its previous sunset report that the provision in existing law that requires the board to approve non-ABMS specialty boards be deleted, and that change is included in this bill. This bill makes technical clarifying changes to make it clear that the Board of Podiatric Medicine is its own board that performs its own licensing functions. This bill deletes the requirement in existing law that the board president cannot be on a disciplinary panel. This bill amends existing law regarding the prompt revocation of physicians who are required to register as sex offenders and changes it to an automatic revocation to allow these revocations to be processed in a more expeditious manner. This bill amends existing law to make it clear that invocation of the psychotherapist patient privilege is not a barrier to the board in obtaining psychotherapy records via subpoena upon showing of a good cause. This bill would allow the board to issue a cease practice order in cases where a licensee delays or does not comply with an order to undergo a physical or mental health examination. This bill amends existing law related to expert witness reports to include additional information that the reports must include and to ensure the board receives these reports in a timely manner. This bill, existing law, requires that if a board pursues and obtains an interim suspension order, it has 30 days to file an accusation. This bill would make that the same for a petition to revoke probation. Have the same 30-day requirement. This board also deletes outdated sections of law related to the board's licensing program, and that's what's our language.
So we have a couple options. These were approved by the board. There are some details here. If you wish that this needs to be reapproved, I have no problem, but I'm taking it for granted that this was the board position, so we don't need to go through. Is that acceptable? You can comment.
Yes.
Okay. So then we go to the next step. Jennifer.
Okay, so we'll just take the first one. So this bill would require on and after July 1st, 2018, for the board to require a licensee on probation pursuant to a probationary order made on or after July 1st, 2018, before a patient's first visit following the probationary order, to provide the patient or the patient's guardian or healthcare surrogate with a separate disclosure containing all of the following information. So it would be 1, the licensee's probationary status, 2, the length of the probation and the end date, 3, all practice restrictions placed on the licensee by the board, 4, the board's telephone number, and 5, an explanation of how the patient can find further information on the licensee's probation on the licensee's profile page on the board's website. So this bill would specify that a licensee required to provide a disclosure shall obtain from the patient or the patient's guardian a separate signed copy of the disclosure, including that information that I just read. This bill that would specify that a licensee on probation is not required to provide a disclosure if any of the following applies. So these are basically the exceptions. The patient is unconscious or otherwise unable to comprehend the disclosure and sign the copy of the disclosure, and the guardian or healthcare surrogate is unavailable. In that instance, the licensee shall disclose his or her status as soon as the patient can comprehend and sign the disclosure, or a guardian or healthcare surrogate is available. 2, the visit occurs in an emergency room or an urgent care facility, or the visit is unscheduled, Or 3, the licensee who will be treating the patient during the visit is not known to the patient until immediately prior to the start of the visit. So those are the exceptions to the probation notification. So this bill would require the board on and after July 1st, 2018, to provide the following information for licensees on probation and licensees practicing under probationary licenses in plain view on the licensee's profile page on the board's website. So, for a probation imposed pursuant to a stipulated settlement, the causes alleged in the operative accusation, along with a designation identifying those causes by which a licensee has expressly admitted guilt, and a statement that acceptance of the settlement is not an admission of guilt. For probation imposed by an adjudicated decision of the board, the causes for probation stated in the final probationary order. For a licensee granted a probationary license, the causes by which a probationary license was imposed, the length of the probation and end date, and all practice restrictions in the on the license by the board. And just so you know, the information that they're requiring the board to put on our website is very similar to what the board is. It's actually the same as pretty much as what the board is putting in its newsletter. So this isn't nothing new that we would have to. It's what we're kind of already doing. It would just be a different placement. So instead of just the newsletter, it would also be on the licensee's profile on the board's website. So do you want to stop there at that issue? And
Yeah, I think we'll take one issue at a time, which were not recommended by the board, which is in the sunset bill. So I'd like to have a discussion first, and then I'll take a motion among the board members, so that way we're somewhat clear where the board is. Dr. Cross.
One of my concerns with a law that requires physicians on probation to spend time discussing their probationary status with every new patient or potential new patient is, will this be viewed by physicians in general as something that would make their continued practice economically unfeasible? And therefore, will the board be confronted with a circumstance where physicians will be reluctant to accept probationary status with stipulations? And will the board be overwhelmed with every investigation and charge leading to a necessity to push for revocation, because we'll have a mass of physicians that won't accept probationary status? So I'd like to hear some comments from Ms. Kirkmeyer in terms of concerns that may exist regarding the potential for the board to be overwhelmed.
So I don't have a crystal ball, but I can say that with the language, the way it's written right now, it's significantly different than what it was before, because they don't have to discuss the reason or anything. They just have to tell them that they're on probation and really direct them to the medical board. That being said, I think any physician is not going to want to tell that to their patient, and so there will probably be some cases, depending on the allegations and the charges of the case, if it's not so severe that they think that they need to have probation, I think that there will be those that would rather take this to hearing. What that number is, I don't know, but any time that there's a case going to hearing, rather than it actually going through the settlement process, Jennifer and I, the analysis we did last year, it costs about $35,000 more to go to a hearing rather than go to through the settlement process. So there's your increase in cost. The one thing is if we put for time and how it will hold up the disciplinary process, the adjudication process. One thing that would happen is if we did put money in on this, so we would be able to say, okay, this is how much it's going to cost the board more because this percentage of cases has the potential to go to hearing. Then the administrative law judges and Ms. Castro's team, the AG's office, because it really wouldn't impact the investigation stage, but those two individuals should be able to obtain more staffing based on the increased cost to the medical board to get that. Jennifer and I've talked about this. We're not really sure now that it's so watered down what that percentage would be of those cases, but that's the impact to the board. So the timing shouldn't be as long as those two entities are able to get the staff that they need for that and increased work.
Dr. Cross.
Is there a concern that if the board is distracted, that the enforcement timeline on other cases will fall behind. Is there the possibility that instead of protecting the public, that if we're delayed in enforcement on other cases, that we may harm the public?
So again, as I stated, if we put the appropriate fiscal on the bill when it goes through, then we would be able to get staffing at both the AG's office and OAH to absorb that additional workload. So it shouldn't impact consumer protection as long as they hire the individuals.
Is there potential for us to support this with the amendment of allowing fiscal to pay those expenses? Or are we going to find that we support it and there's no money to pay those expenses?
So we're actually, Jennifer hasn't gotten to it yet, but there's actually a section of this law that says that the board can ask for cost recovery. So the cost recovery isn't OAH, but it is the AG's office, and so we would add those additional costs to that physician as they go through the disciplinary process. There's other recommendations you could put forward, maybe only having certain cases go into this requirement. That's another option for the board to do. When it went through before, we kind of looked at that and thought about maybe there's just certain cases. We were going to go down the process of doing regulations for the disciplinary guidelines to allow us to have the opportunity to choose which cases we wanted to do. So maybe you could think about that, cases that involve certain aspects, sexual misconduct, conviction of crimes, in the line of the practice of medicine, individuals who have had prior probation. Maybe you want to think about those individuals would have to notify their patient. I mean, there's a lot of options, or you can just outright say, we don't think that should be. But that's up to the board. And then what would happen is, because it is a large bill, we would go forward, we can because this is our sunset bill, so we're obviously going to support it, but we could support it if amended with changes. And those would be our amendments, but obviously we would support the bill. But we would have amendments that we would take back to the author. As you all know, that this is an issue that this author feels very strongly about, but at least we could give them our amendments, whether they take them or not, then would be left up to them at that point.
Okay, Ms. Lawson.
So I've put a lot of thought into this issue in particular because it's been bouncing around out there for so long. And I think probably we could all agree, I'm only going to speak for myself, but I think we could probably all agree that the more information that patients end up with, the better. And how we get that information to them, whether we require doctors on probation to provide it to them, whether we make best efforts, I really fundamentally believe that the more information they have about their healthcare providers, the better. What continues to come up is a legitimate concern that a bill like this has unintended consequences for patient care, for patient safety, because potentially our enforcement timelines could be extended. We'll have physicians who try to use process to delay the imposition of discipline. And so I think where we should focus our discussion and where I would like to see the board focus the discussion is on, well, what are the most egregious cases, or how could we try to solve for those unintended consequences? But the more we talk about, well, physicians just don't want to provide the notification, that doesn't resonate with me at all. I think, frankly, the physicians, if they're on probation for certain types of violations, should be required to provide information to their patients. But I do recognize that there could be unintended consequences, slowing down the timelines. And so if we focus on, focus on the types of violations where no matter what, physicians are, going to end up on probation, or where they settle. We see them all the time on our panels. I think we would do ourselves a favor as we go through the sunset process.
Thank you. Dr. Lewis.
Yes, I 100% agree with what you're saying. So I agree with the more information, the better off the patient is. We've had these discussions for quite a number of board meetings, and I think with Jennifer and Kim and the rest of the staff kind of knows the flavor, the feelings, the comments that have gone back and forth. And I'm going to ask you more of a procedural thing. Is it better now not to come up with those lists of egregious activities that we really want to have out there, for disclosure, but maybe do the support if amend, and you sit down with the author, you know the comments like Ms. Lawson said, and Dr. Kraus and other people, and come up with a better working document for that. Tell me.
So we have to work at your direction. So we need your amendments. We need, quite frankly, now is the time for this discussion, and we need you to tell us what you think those egregious violations are, because we need to go back your direction to tell them what the amendments would be, because our next meeting isn't until July, and that's very late in the process. So
We don't need exact language, but like
right,
a
not language,
concept of
but
what you guys are
what you
thinking.
think, what those cases are. Like I said, there's sexual misconduct. There could be
fraud.
So,
criminal
Criminal
conviction,
convictions.
those that are already on probation.
any other comments? I spent a lot of time thinking about this, talking to people there in the legislature and talking to our staff. So I have a few, but I want to hear yours before I can give mine.
I would
Dr.
just say
Cross.
that regarding direction from the board to Kim and Jennifer, I think our principal concern, of course, is protecting the public. And as part of that, our concern is being able to do the job that we have been doing. So I think that the give and take with the author of the bill has to be in relation to not wanting to have a medical board that shoots itself in the foot. So I don't think that we can prescribe for you what to do, but to keep in mind that our primary concern is being able to do the job that we have been doing.
So,
Any other comment before I make my comments? So I just want to hear everyone out before I do.
Sorry. I think we should add it to the guidelines as an option for us to consider when we put a doctor on probation. Because if we add something like a criminal offense, there are doctors that have a criminal offense for tax evasion. And some of the tax evasion could be they were out of the country for a year, thought their accountant did it and did not do it. And I would not want to see that doctor have to tell his patients that he has a criminal record and it was for something like that. So when we talk about unintended consequences, those are, there are so many different reasons why something occurs. And this just gives a blanket indication that all doctors put on probation are all bad doctors and we need to all watch out for them. And that is not the truth. So I think that we will find ourselves down a really slippery slope of finding ourselves back here again with lots of numerous issues and issues that relate even into the community. So those patients who rarely even go see their doctor will use that as an additional excuse not to go see their doctor, and especially in areas that don't have that many physicians to begin with. So the unintended consequences are so many with this one decision. And so I'd like us to, really consider that at least adding to the guidelines will give us an opportunity to consider that when we know there is a particular doctor we feel this way about.
Any other comments? So I spent some time with the staff and talked about it, and a few things which came to my mind, I will express now, is that number one is sexual misconduct. Inexcusable. The relationship between doctor and patient is doctor has a lot more power over a patient. You should not have that. Second one is, as Ms. Pines mentioned, criminal prosecution related to practice of medicine. It has nothing to do with tax evasion or something else where they are done, but it's Medicare fraud, Medi-Cal fraud. So this is practice of medicine, so it's specific to practice of medicine. Third one is repeat probation. And fourth one is practicing under the influence. Means that somebody actually went to a hospital drunk and practiced, not somebody just got a DUI, made a stupid dumb mistake and got a DUI. So these were the thoughts I had. I just wanted to hear you out first before I gave my thoughts, and you can add. These are just giving to what our thoughts are to the staff so that they can take it, because we can't just say blank, go and see we can get amendment. So we need to give some direction to the staff, so there are certain things we agree on, if we agree on. So I would like to hear your comments on that. So,
I feel very comfortable with those four areas. Those are egregious, and I think that patients or potential patients will be entitled to know those.
Thank you. Any other comments? Yeah, Dr. Cross.
I do like Ms. Pine's suggestion that rather than the law prescribing which class of physicians must inform, that the board be authorized to set that as an additional requirement in a probationary process. Because we're the ones that are reviewing the individual nature of each case. And if we have the authority to require that, we can use that judiciously.
Jennifer and Kim, you have any comments on that? I would love that, but I just want to hear the staff comments.
We did testify and actually met with Senator Hill, and we did tell him that's something the board is considering, and I don't think that is swaying his, he still introduced this bill, and so he knows that's something the board's considering, but I don't think, he already knows we're doing that, so.
I don't want to speak on Senator Hill's behalf, but I don't think that would be enough for him, because there's the potential that then that will never happen, because we never put it in, so.
Okay, so Dr. Yip, then Dr. Bishop, and then Christian.
I think we need to accommodate both, that we have certain category, very obvious. All panel members agree that needs to be reviewed to the patient, and some leeway, certain cases that the panel, the staff can have a judgment on based on experience that the physician need to be one of the conditions to review to the patient that he's on probation. The gray zone, the cases like that, but certain category, everybody agree that need to be on the panel. On the panel. So.
Dr. Bishop.
Can we do a hybrid of what Ms. Pines has said and what Senator Hill kind of wants, where we have, I think what they've alluded to is having a certain number of ones that we list specifically, and say the board also has the option to impose this on particularly egregious cases requiring this for patient safety, something of that nature. So that there are certain things that they know are going to get flagged every single time, the big low-hanging fruit that he wants off the table, and I agree with that. But there are other cases where maybe a surgeon has had 10 different things happen terribly over his career, or perhaps a certain number of lawsuits or 805s. There's a number of things that we should have some discretion on. And again, every time you try to enumerate every single thing, you're going to fail. There always has to be some latitude in what you're going to do. So I think trying to let him know we're serious by presenting a number of the really egregious ones, and say that we anticipate we'll use this in other circumstances where we feel it's indicated.
Thank you. Ms. Lawson.
So I actually like that approach. What I was going to ask a question about is whether Senator Hill would consider some type of amendment that defined who needed to be notified as major or egregious, or some term, and then allowed us to regulate as to what that term meant within a certain defined period of time. And I think there's actually a hybrid between these two approaches, which certain violations are just automatic notification, and then there's this catch-all that says, and other major violations, and then there's a requirement that that term major be defined by this board via regulation in some period of time.
You could do that, or you could just do a catch-all like any other, case the board believes is appropriate for this kind of notification, and then we don't.
I mean, I want to get at this issue, though, that they think we're going to do nothing, because I think they do think we're going to do
But
nothing.
adding that to that four,
Right.
maybe that Dr. Gondov says, so that'd be like the fifth one, right? And it's like, if
Exactly,
there's something that
exactly.
doesn't catch the four, and there's something that the board believes is egregious enough that we could do that.
And that eliminates us from having to go through the regulatory process, actually did change our disciplinary guidelines, because it's already in the statute.
Right.
And then you have the ability just to add it to any decision as it goes through the process.
Right, I guess my concern is, will Senator Hill believe that we will actually ever add it, to any other additional? And so, I guess my fallback on that is, well, then he can tell us that we need to regulate as to what those defined categories are. But anyway, so I think there's actually an approach in here that could
I think you're looking at the hybrid. From what I'm hearing, it's like, okay, we give him maybe the items that Dr. Gonadev has put forward. I think I wrote those down. So those 4 items, you put those forward to him and say that we would go forward with any probationary decision that has that. Those individuals would automatically have to notify their patients. And then one catch-all that says, in any other major at the board's discretion, any other major violation that needs to be notified. And then when it comes to you during the stipulation process, or even through a non-adopt, then you would be able to do that. Because I think you're getting to, you have some that are for sure, and others that are left up to your discretion to add.
Mr. Varma.
My question basically, or my thought is that we kind of add a hybrid to the hybrid, which is the issues that I've heard most frequently are that we believe that it will slow down enforcement, but we don't exactly know how much, and that it will cost a great deal more, but we don't know exactly how much. I would ask that we try to put a sunset on the sunset and put a term for how long we do this hybrid, and then consider whether or not it's cost and enforcement effective.
David, I would love to agree with you, but I don't want us to be back again in the legislature for 4 years. Let's get it done and move on. It's painful. Let me put it that way. Any other comments, Dr. Cross?
I want to be sure before we leave this issue today that our staff be acknowledged for the incredible job they've already done in terms of public access to information. Consumers Union published a survey last year on access to information available to the public in each and every state, and California was listed as the best and the most accessible. So it's not without a small degree of irony that California is the only state facing this requirement of probationers having to inform patients. But I do want to be sure that our staff is acknowledged for the incredible job that they have done bringing us to number 1 in the state in terms of public access to information. Thank you.
Thank you, Dr. Storr. Any other comments? And so these are such special issues. I thought I would take comments on each one of the 2 or 3 issues we're going to talk about. So I'll take the public comment now on these issues. So we have some slips, I think. Yeah, that's fine. I think just come on forward and introduce yourself. We know most of you, so.
Good afternoon. My name is Michelle Montserrat Ramos, and I'm with Consumers Union Safe Patient Project. We're asking you to support the probationary notification portion of the bill. And as an aside, I have to say the reason why I've spent the past 12 years of my life coming before this board is because my late fiance's doctor was a substance abusing physician, and he had a long arrest record for many things, including felony possession of crack cocaine. Saying this, consumers are counting on you to ensure that we have adequate information to make the best possible healthcare decisions for ourselves and our families. We have the right to know our physician's background, just like he should have had the right to know. The impact on the physician is minimal. Your mission is to protect consumers and California patients. We've been advocating for this issue for a while, and we urge you to support this portion of the bill. Thank you.
Thank you, Ms. Ramos. Next person.
Hello, my name is Marion Hollingsworth, and I'm a member of the Consumers Union Safe Patient Project. I want to urge you to support the patient notification in the area of probation. If you really want to protect the public, you need to inform the patient, not hide this information from them. This should be required for all of the egregious cases of patients, of doctors who are on probation. And the thing that seems to be missing here is this is just a few hundred patients, a few hundred doctors. Why protect a few hundred doctors who are actually dragging down the reputation of all doctors and the reputation of the board at the same time? This goes down to informed consent. Patients are supposed to be able to know all the risks and benefits of any procedure or treatment, and the background of their doctor should be part of this informed consent process. By leaving it up to the patients, they can decide, they can have more power. For example, you might have the best cardiologist in the world, but he's on probation for having a consensual affair with a patient. For some people, this might be a deal breaker, but most people, I think, would say, maybe he's a jerk in his personal life, but if he's the best, I want him for my surgery or for my loved one's surgery. But it gives the power and the informed consent up to the patient. The bottom line is a patient should know about the doctor's background. Breeze, even though it came out well, it still has a lot of issues. It still is hard for people to interpret, and most people are not going to look up their doctor every single time they go in for bronchitis, a twisted ankle, an earache, whatever. California should lead the nation in this and be kind of a guiding light for other states that might be afraid of this issue, and I think you could really make a statement by coming out in favor of the patient and the patient's right to know. So, thank you for your time.
Thank you. Next.
Sarah Davis with the California Association of Licensed Midwives. This is all licensees of the board, right? Or is it only physicians?
It's only physicians.
Okay.
Let me look into
It would end up applying to some other providers like osteopaths, podiatrists.
Yeah.
Would it apply to licensed midwives as licensees of the board?
It's not included right now.
Okay.
It will be guaranteed, it will be included afterwards, but go ahead.
Let me add that licensed midwives already are required in statute to disclose a license status at the first appointment. So I was going to ask a separate question if we were included, but we're not, so.
Anyone else? Ms. Feldman.
Good afternoon, Julie D'Angelo, Falmouth. I have a suggestion rather than a comment. This is how serious Senator Hill is about this issue. You may not know this, but the background paper on the medical board's sunset review was about 150 pages long. At least 90 pages of that was a giant chart of every doctor that's on probation in the state of California, what that doctor was charged with doing, what that doctor accepted probation for, what the penalty was. Some of those cases are just horrendous. They're just egregious, which has led to that bill, AB 505, which would preclude you from putting doctors who have done certain things or have been accused of doing certain things on probation. I suggest that in addition to the 4 categories that Dr. Ganadev mentioned, you look through that 90-page chart and pull out some other very serious violations that doctors have committed and have been put on probation for, and that disclosure would be entirely justified for. Thank you.
Thank you, Julie. Actually, I've seen that list. I was there testifying, so I appreciate your comments, and that's why our hybrid model, which already we talked about, where anyone else, the board feels that it's an egregious offense, can be asked to do so. Thank you. Next.
Hi, Shannon Smith Crowley, are you taking testimony just on the probation issue or in any other issue?
Just on this one.
Okay, I'll be back for when you open it to other issues.
Thank you. Any other comments from the audience? Comments on the phone?
Yes, we have a comment from Alicia Sanchez with California Medical Association. Please go ahead.
Thank you, Alicia Sanchez with the California Medical Association. We are opposed to the provision in SB 798 related to probation notification. For some of the reasons that were raised in the discussion earlier, we do believe that physicians will be loath to settle cases with probation notification and disagree with the assertion that the impact on practice is de minimis. Because of that, because it would function more like a de facto suspension, we think that people will seek to have their cases heard all the way through. And so we remain opposed.
Thank you, Alicia. Any other comments on the phone?
We have a comment from Eric Andrus with Citizen. Please go ahead.
I have a couple of replies to Dr. Krause's statements. He mentioned that he thought that doctors would probably try to avoid getting probation, but Dr. Ganadev said at the sunset hearing that the medical board doesn't want to put people on probation, that they'd rather just flat out revoke their licenses, which I think is kind of strange. Also, he mentioned that the Consumers Union came out with this list of all the good medical boards and how well the California Medical Board did, but I have a letter from Consumers Union's Lisa McGifford talking about how they were disappointed in the results, and that the list, it's almost like if you have a list of murderers going from the least bad murderer to the worst murderer, there's always going to be one at the top that's not as bad as the rest. That's what the California Medical Board is in that chart. You guys need to stop patting yourself on the back so much for all this good work you're doing, because I wrote a report that I turned into the Business and Professions Committee called The Medical Farce of California. It's 200 pages, and if you guys haven't read it, you should. It's available at bit.ly.com ADVMBC Sunset. It's 200 pages of the problems with the medical board. In the back of that is 100 articles of how the medical board has been screwing up over the years. So to think that you guys want to keep sunsetting, giving yourself 4 more years to protect the public when you're not protecting the public in the first place is absurd. You guys are put into office to protect us. Don't keep doing things bad and then giving yourself a pat on the back because you think you're doing such a good job and then giving yourself 4 more years to protect us when you're not. There's article after article after article talking about how bad the medical board is. Read the report. Read what citizens are telling you. Listen to what consumer organizations are telling you. Stop patting yourself on the back.
Thank you, Mr. Andrus. Any other phone?
We have a comment from Khadijah Lange with President Golden State Medical Association. Please go ahead.
This is Dr. Khadijah Lang, President of Golden State Medical Association. In addition to all the other comments that have been heard today against this bill, I'd like to add Golden State's concerns. We're concerned because not only does this put physicians of color, and those are the ones most likely to work in underserved areas, at risk many times because of the lower profit margin in poorer doctors' offices and those that take the risk of working in underserved, medically underserved communities. They don't have enough money. It is very expensive to fight a medical board charge. Most attorneys are starting at $70,000 for a retainer fee. If a doctor is practicing in an inner city area, getting a very low reimbursement rate for the patients they're seeing that are very sick, and they have to make a choice between coming up with $70,000 cash to give an attorney to defend them, or, well, you could take probation and keep on working and do whatever other things are recommended and required by the board to continue practicing. Many doctors who have not even done something wrong, but just don't have the money to be able to legally fight the case, will take probation so they can continue taking care of the patients they're serving. As I have mentioned at previous hearings, these physicians are frequently serving very large numbers of patients because so few physicians are willing to work in those conditions for such little funding and reimbursement. The impact of this is going to be far larger on your medically underserved communities, your minority ethnic populations, where the doctors frequently are not making enough of a profit to be willing to fight if it's something relatively simple. And they may just say, probation, because I don't have the time and the money to sit with attorneys and go fighting the process, so I'll just settle for probation and keep on moving. This is going to impact a much larger number of patients in those areas, which in turn will mean emergency rooms and hospitals will be overrun with patients who can no longer get primary care because their doctor was forced to try to fight something that they didn't have the money to fight, rather than be on probation, because the patients that are less educated will have much more trouble understanding what's explained to them when a doctor says, oh, I'm on probation, but don't worry, it's not for the following four categories that are really egregious. There was a billing issue, or there was a tax issue, or I didn't pay my spousal support, or there are many different things that doctors end up on probation for that don't impact how they take care of their patients, and the patients may not necessarily have the capacity intellectually or the socioeconomic understanding of all of those things. Realize the real...
Please conclude.
I would just like to say that Golden State stands opposed to this because we don't know that it will really benefit the consumers that we're trying to take care of.
Thank you, Dr. Lang. Any other messages on the phone or comments on the phone?
No further questions.
Thank you. So this, Dr. Kraus.
I'd like it entered into the record for correction and evidence that it was the April 2016 Consumer Reports that reviewed all of the medical boards and public access to information, in which California was rated top of all states in the nation.
Thank you, noted. Okay, Jennifer, next item.
Okay, the next item has to do with the vertical enforcement and prosecution model. This bill would repeal the existing vertical enforcement and prosecution model. Although VE is an issue the board has reported on in the past, the board did not offer this language to the committee. This was something that was that they did on their own. The board has been Dr. Gonadev and others testified at our hearing. We were asked specific questions on the VE model, and at that hearing, and I can let you talk about this, Dr. Gonadev, but we did talk a little bit about VE is good in certain cases, and so board staff has been working on some language. It hasn't been submitted to the committee yet, but I don't know if it's something you want me to go over, the language, or...
Yeah, go ahead, please.
So when we were talking about this, when we got questions at the hearing, we were asked to, look at if there was certain types of cases that VE could be good at, and we've been working with staff and on the kind of cases that VE actually does provide a benefit. And so what we came up with is any complaint presenting issues of sexual abuse or misconduct as described in Business and Professions Code 726 and 729. Any complaint presenting issues of mental or physical illness as described in Business and Professions Code Section 820. Any complaint filed against a licensee who has a prior disciplinary history, is currently on probation, and or has an accusation pending. And then any other complaint, including complaints presenting issues of endangerment as described in Government Code Section 11529, and complaints presenting issues of prescribing privilege abuse that the board,
in furtherance of its public health and safety function, decides shall be handled in the vertical enforcement and prosecution model. So those are the cases we actually think that VE provides a benefit, and let the board's discussion is what is better of getting rid of VE or actually including some cases that would go through VE. So.
Okay. Ready for comments?
I don't know if you have anything to add, Kim, to what I just said, but.
Kim?
No, I mean, I think we've looked at this over and over again, and I think that from our perspective in looking at it, and we've been actually meeting with the Attorney General's office and with the Department of Consumer Affairs and with our Business Consumer Services and Housing Agency. They've all been having meetings, and I don't think that any of us believe that an outright removal of vertical enforcement because of the unintended consequences that would come from that is the option to go, but we do believe that there needs to be changes. We've all sat here and lived through this for the last several years, and so we do believe that changes need to be made, and we think that this is one step in the right direction to limit the types of cases that would be required under VE. But then the more important thing really is to give us that discretion to say we could put other cases in as they're going through the process if we need to put them into that process, which we do think there are those. It's just being able to identify what all of those are is kind of difficult, so we want to have that discretion of the board.
Okay.
And that's Dr. Gonadev and Ms. Pines too, when we met with agency, that's kind of what we talked about.
Yeah, we met the agency, we met Senator's office, we met DCA. As Kim mentioned, or Jennifer mentioned, that this elimination of VE was never recommended by us. Just want to make sure that everybody is very clear on this one. So it's a streamlining which works. That's all we're looking at. With that, I will, if no comments from the board, I will ask the public comment. Public comment, I'm sure Julie will be first one.
Thank you. Julie D'Angelo Felmuth from the Center for Public Interest Law. As you know, this bill proposes numerous changes to the Medical Practice Act, and today I'm not going to take a position on any of them except this, the repeal of vertical enforcement, which involves the amendment of Business and Professions Code Section 2006 and the repeal of Government Code Section 12529.6, which we strenuously oppose, by the way. Thank you, Dr. Gonadev, for clarifying that this board has never proposed or supported the outright repeal of VE. In fact, this board has not proposed or supported the alternative that that your representatives presented at the sunset hearing, which is to limit VE to certain kinds of cases. That was proposed by staff in February 2013, and it was rejected by this board. This document that I've given to you, also that discretion that you say you want, is not in this bill. The document that's just been distributed to you is from your January 2017 meeting materials. It shows you that the use of VE has reduced your investigative cycle times by 30%. Look at the data up until January 1, 2014. In 0809, it took an average of 349 days to investigate your cases. They got that down to 245 by 2013-14. That is a 30% reduction, and that is nothing to sneeze at. What happened on July 1, 2014? Your investigators were moved to the Department of Consumer Affairs. Look at the case cycle times since then. They are skyrocketing, and that trend shows no sign of easing. Why? Because the investigators who work your complex cases are working next door to and alongside other investigators who are working much less complex cases for the same pay. Your investigators are leaving for other agencies that have lower caseloads of lesser complexity and higher salaries. As of the date of your sunset hearing, which was February 27 of this year, there was a 41% vacancy rate in the investigative positions assigned to this board. That is the problem. VE is not the problem. VE has not changed during this entire time frame. What has changed is the employer of the investigators who work your cases. You want discretion to figure out what kinds of cases should go through VE and which need not. I would suggest that you have it. You have sat down and negotiated and worked with the AG's office over the course of many years prior to July 1, 2014, and agreed that certain kinds of cases need not go through VE. All that's been agreed to. Nothing in the current law precludes you from engaging in that kind of negotiation with the AG's office, either in the past or in the future. But this bill does not give you that discretion. It simply repeals the entire vertical enforcement with statutes without replacing them with anything. Doing that will mean a return to the old prior handoff method where an investigator, unassisted by any attorney, investigated a case unilaterally and then handed it off to a prosecutor who had no role in designing the investigation and who has no investigative assistance thereafter. Can VE be improved? Certainly. I hope this is a work in progress. I'm happy to hear you acknowledge that you don't support or have never suggested a repeal of VE. But we need to work together to come up with a meaningful opportunity which preserves attorney guidance of investigations in appropriate cases. Thank you.
Thank you, Ms. Falmouth. Kim?
I just want to point something out. Julie, I knew you were bringing this, so I brought my own data too as well. I just want to point out that if you go back prior to VE, though, because the date that is being looked at here is the 2008-2009, that was actually after VE had been in place for 3 full fiscal years, which again had, there was growing pains and everything with it. PRAC in 2014-15, the average time, or 2004-2005, way back when, the average time for investigation was 259. The year 2003-2004, it was 220. So just when you're looking at numbers, you really have to go back to the numbers that were pre-VE. One thing I do want to preface that, though, is I know that at one point we did have other things that were changing our time frames, other numbers included in there, and I just didn't have time to go and analyze that. But I do want to make sure that everybody knows that this 349 was when we were in the middle of VE. So it's that time decrease, and granted, that was a yeoman's effort to get that time down during that time frame. But I do want to say that our time frame without VE was low as well.
Thank you, Kim. Any other public comment from audience here? Any comments on the phone?
We have a comment from Eric Andrus with Citizen. Please go ahead.
I just wanted to get one more comment in since Dr. Kraus did. This is from my March 29th, 2016 email from Lisa McGifford of Consumers Union. We were also dismayed that California came out on top since we have been complaining so much about their site. But this review is comparative, and frankly, most of the other sites have a lot of less info and are a lot more unfriendly, if you can imagine. We reviewed each site based on 61 criteria, and a lot of the things you mentioned were not on the list. Not that they are not important. We just had to limit the list in some way. We do talk in the report about all the sites being less than optimal. Here is from our executive summary. The highest-rated websites had comprehensive information gathered in a physician profile for each licensee, but most sites were difficult to navigate with a variety of user barriers such as confusing entry points, long drop-down menus, security codes, or information in multiple places. And we found medical board websites that were being very slow in bringing up names such as California and Hawaii, dropped parts of the names, and sent us to dead pages. California was very slow compared to most. Thank you.
Thank you, Mr. Andrus. Any other comments on the phone?
No further comments.
Thank you. Any comments from the board before we go to the next item? Dr. Kraus.
Did I hear testimony that stated or implied that a well-intentioned act of our Senate that moved our investigators to the DCA has perhaps made our job more difficult?
We heard actually this board took a position when these investigators were moved that the support, if amended, was the amendment was not to move the investigators to the DCA. So on this board's portion stays the same unless a board member wants to make a motion that we don't want them back. We do want them back.
I think it's important to engage the Senate as our partner in our mission to protect the public and to remind them that sometimes well-intentioned acts have unintended adverse consequences.
We do. Our staff will work with the Senate, and it's our intention to really streamline the process, and we think our investigators back in our homeland here is much better off rather than somewhere else.
Thank you.
And I'm stating the position of the board, it's not my position, and mine too, but anyway, next item.
Okay, the next item has to do with doctors of podiatric medicine. This bill would allow a doctor of podiatric medicine to advertise and use the phrase podiatric physician and surgeon, and would allow a DPM or doctor of podiatric medicine to advertise as podiatric physician, podiatric surgeon, podiatric physician and surgeon, and foot and ankle physician and surgeon. This bill would also add doctors of podiatric medicine to the definition of attending physician in the Health and Safety Code, which would allow DPMs to recommend medical cannabis.
Comments from the board? Yes, sir, Dr. Kraus.
Again, I'm reminded that our mission is to protect the public. So whenever the term physician and surgeon is utilized, we endeavor to be sure that the public isn't misled in terms of whom they're seeking care from. I actually don't object to the identification of a podiatrist as a podiatric physician and surgeon, because the podiatric training in their scope of practice is really on par with medical training in the care of the foot and the ankle. And there's no concern that someone would call a podiatric physician and surgeon and ask for a examination or appointment for a part of their body that isn't within their scope of practice. I've become more concerned if there are other practitioners where the use of that term would bring harm to the public. And I don't know that this would be harmful to the public for them to be known as podiatric physicians and surgeons.
Any other comments? Just my comment is, usually physician and surgeon is a term limited to an MD or a DO, period. So it's not a doctor, it's a physician and a surgeon. It's a completely different term. So it just concerns me somewhat. I know they do go through training, they do go through that school, but what next? What next is the one which worries me. Then you don't want to dilute out that term. So that's my feeling. If anybody else have any feelings, let us know before we go to public comment. Okay, so any comment from the public in audience in here? I know it's not an exciting issue here, so any comments on the phone?
No comment.
Thank you. Next.
Okay, so we talked about this a little bit already, but the board is currently prohibited from recovering costs for investigations and prosecutions for disciplinary proceedings. This bill would allow the board to recover these costs from licensees. This bill would not make changes to the additional $15 fee all licensees are currently charged in lieu of cost recovery, so we'd leave that the same. So open it up for discussion.
Any comments here? I was told that $15 in fee was allowed when we did not, when the legislature said we couldn't do cost recovery. But I'm fine with it. I would rather use that to pay our investigators. Any comments? Audience? Comments on the phone?
A comment from Alicia Sanchez with California Medical Association. Please go ahead.
Yes, Alicia Sanchez representing the California Medical Association. We're opposed to this provision. When as you mentioned, Dr. Gonadev, when this provision was amended into the statute, it did accommodate for the change with a fee increase across all licensees. And by removing or allowing for cost recovery without lowering the fee, you're essentially going to have physicians paying twice those that are having cost recovery, and we would seek to have either of the provision added back in and maintain the prohibition against cost recovery, or see the fee lowered. I would also note that other boards that have this authority have not seen 100% collection on those cases where they have cost recovery, and in fact, some of them have had very low rates of return on getting those funds back. And so it really is not that effective of a process.
Thank you, Alicia. Any other comments on the phone?
No further comments.
Any other comments from the board? Okay, so last item, I think?
There's a couple more little items. I can just clump them together if you want.
Yeah, can
So,
you please? Yeah.
in response to stakeholder feedback, this bill would include licensed midwives and the peer review reporting requirements and provisions in existing law. And it would also add licensed midwives to the listing of medical corporations.
What's the staff recommendation?
This wasn't a staff record, but we don't have any, staff doesn't have any concerns with that.
We believe both of these are actually important for consumer protection.
Any comments from the board? Okay, comments from the audience? Please, identify yourself. Thank you.
Hi, I'm Rosanna Davis. I'm a licensed midwife practicing in the San Francisco Bay Area since 2004. I'm also the president of California Association of Licensed Midwives. SB 798 has these provisions related to licensed midwives for the benefit of patient safety and quality improvement. COM was shopping this language with these provisions, and we were invited to submit them directly to the Business and Professions Committee under the Medical Board Sunset Review. Licensed midwives are regulated by the Medical Board and are independent healthcare professionals who offer prenatal, birth, labor, and postpartum newborn and family planning care to clients who are healthy and experiencing normal pregnancies and births without complications that are likely to affect the pregnancy and course of care. Like other healthcare professionals, licensed midwives use individual practice protocols as well as national and state professional standards of care to provide individual education, evidence-based information for their clients. California licensed midwives also reference a comprehensive practice guideline adopted by this board and that's published on the Medical Board website. We are licensed, we are educated through schools approved by the Medical Board, and there are detailed statutory and regulatory requirements for that education content. Integrated throughout all midwifery education and practice is the ongoing risk assessment, informed consent, and associated health education for our patients. LMs identify major risk factors early and promptly engage the client in education and behavior changes so that these minor risks can be mitigated with emphasis on prevention and wellness. When ongoing or acute complications or conditions arise, the licensed midwife refers the client to a physician trained in obstetrics. Licensed midwives are also emergency first responders that quickly resolve unanticipated situations that arise that need prompt attention. We would appreciate your support of the provisions in this bill related to licensed midwives, which are in the interest of public safety, patient safety, quality improvement, including, and this would be especially to include LMs in professional peer review.
Thank you.
Thank you.
Okay, does that conclude your?
Oh, there's
Okay.
one last item.
We have one more person, please come on. If you can make it brief, would really appreciate it, especially if you're in support of it, so.
Okay, sure. My name's Sarah Howard. I'm a licensed midwife practicing in Los Angeles, and I love what I do, providing out-of-hospital birth. I also am the mom of double breech twins born at Good Samaritan Hospital, so I also love doctors and what you all do. I do urge your support of the legal protections for peer review activities for licensed midwives. This really does support the quality assurance measures that we already do. Particularly, most recently, I worked at an accredited birth center for the past 2.5 years, and there we have rigorous chart review that we do. We audit every single transport that we do, in addition to a randomized 10 to 20% of all of our monthly cases. So protected peer review would be a great addition to that quality assurance process. So thank you so much.
Thank you. Any other comments from audience here? Any comments on the phone?
No comment.
Thank you. Jennifer, does that
The last
conclude?
item.
Oh, okay, one
This
more.
bill would transfer research psychoanalyst to the Board of Psychology. This was brought up in the background, the Senate BMP background paper, as psychoanalysis is a discipline of psychology, and board staff doesn't have any concerns with this.
Okay, any comments from the board? Any comments from the audience? Any comments on the phone?
No comment.
Thank you. So Jennifer, in summary, your recommendation is support if amended.
Right, if the board believes that there's amendments, obviously we should
Yes,
support
there are, so.
support the language that we requested, and then decide what amendments we.
And Ms. Kirschmeyer will go through the amendments.
So if I have anything wrong, please let me know so we can make sure that we give Ms. Simoes the correct direction. So basically, I think we're okay with everything in the bill with the exception of the following amendment. So for patient notification, it would be that we recommend the 4 items that we put forward, that Dr. Gonadev put forward as items that patient notification would be required on, with the caveat that there's another catch-all for major serious, allowing the board the authority to do that. I didn't hear a lot of support with the sunset date, so I didn't put that in there. And then for vertical enforcement, it would be to amend the current language in there to include the 4 items that Ms. Simoes requested, that we would include in VE, and then give the board the discretion on everything else in there. Everything else I think we're okay with.
Just one, publicly, it's a public thinking. Is it worth adding on that we want our investigators back? Just.
Trying to kill us? No.
Yep. Is it gonna be a issue?
No, the reason is it's not about that we are possessive. I think it is a serious issue where the enforcement timeline doubled. So our goal is to actually, our job is to really keep the timeline in, not that long. So that's why I'm just asking the board, would you want to have that? I know staff, we are working behind the scenes, but if you want that in the amendment.
Doesn't
Dr.
hurt to
Bola.
ask.
I was just gonna say, there's no harm in the asking.
No harm in asking.
I would be supportive of that.
Dr. Cross.
In reviewing the amendments as recited by Ms. Kirkmeyer, I don't think I heard the earlier discussion regarding fiscal recovery. And I would hope that there's a way of this bill recognizing the increased costs of probation notification, and that those would be recovered.
So it's the cost recovery requirement is in the current
I
bill.
see.
That's
Yeah.
what, when Ms. Sanchez called in with that.
And the other thing that ordinarily is done with every bill, and I believe is required by law, is some state government agency that does a economic analysis. And I would hope that you would have the opportunity to convey to whichever agency does that there are costs in our delayed enforcement process that should be included in that analysis.
Ms. Mose and I always work on the fiscals on these. This is a difficult one, but we'll go back and kind of get a percentage of what we think. Again, we really have no idea how impactful. I think that's what Mr. Wormuth was trying to state. We don't really know the impact of it until it happens, but we'll get a percentage of those cases we actually believe will now end up going to hearing that wouldn't have before, and we can pull that out.
Even in the lack of certainty, it's sometimes helpful to give a range.
Yeah, and that's what we've done.
Okay, Dr. Yip.
You've been here so long, many years. From your experience, if moving the investigator back to us now at this time, this year or next year, any change in the vacancy rates of the investigators?
You guys are really taxing me today. Trying to think future. I think, actually, Kathleen, I was gonna call upon Ms. Nichols. I think she said it, and shake your head if I'm in the right vein of what you said up here. By our investigators going over to the Department of Consumer Affairs, they are working side by side with individuals whose caseloads are lower and whose cases in some instances are not near as complex, on top of the fact that they're also doing VE. So when you put them in that realm where now they're really interacting with these other individuals, they go to probably range together, they have meetings together, and you have these two individuals discussing their caseload, a lot of
their
individuals
salary.
are gonna like jump ship because they're paid the same. So bringing them back to the medical board, and I think there is some semblance, I may be speaking completely out of turn here, but I think there is some semblance with the investigators that they don't feel that they have a home maybe at the Department of Consumer Affairs. Not that they don't have a home, but they just aren't they're still kind of part of the medical board because they still do our cases. And so I think having them under the medical board gives them that, they're still doing our cases, so why aren't they with us? I may be speaking completely out of turn, but
So
I
they
think
have better
if you ask
retain-
them, they were happier here.
Okay, so can we have a motion?
I'll make a motion to support if amend with the amendments that were mentioned, and including vertical enforcement.
Okay, do we have a second? Okay, any further comments from the board? Comments from the audience? I know you've been
I
waiting.
have a question. You first mentioned that there were items that they didn't consider that we had interest in it, being considered. Can you just run through those? Or either, is there something that was really important that we really feel should have been included?
One of the main ones I can think of, and Kim talked about a little bit at the licensing committee, was the competency returning to practice. That wasn't included just because, like Kim said at the meeting, that we might need to have a meeting with him and kind of explain the proposal. They didn't feel comfortable at this point in time and kind of including that. I can't remember any offhand. I didn't bring the list. I'm sorry. I can get back to the board members on if there were other, but that's the most significant one I can think of.
Okay.
Yeah, reentry.
Okay, so I'll go back to audience comments. Yes, ma'am.
Shannon Smith Crowley, and I'm a new persona right now. I'm representing the American Board of Cosmetic Surgery and the California Academy of Cosmetic Surgery. And an item that was mentioned but not discussed was the elimination of the equivalency procedure. And we have an opposed unless amended position on that, and we'll give Ms. Simoes the letter on that. The board is in the middle, the American Board of Cosmetic Surgery is in the middle of their application process for the equivalency recognition or determination. And to have a sunset date of that of January 1 of 2018 would likely interfere with that. Also, even without our specific application, we do think that the board has used this, is actually proven to be quite adept at this process of looking at other boards for equivalency, and you've approved 4 out of 6 applications. So we believe that the process established by statute is working. We have also, though, if the board is this something that the board doesn't want to do, we do request that you continue in this role until an alternative process is found, because just relying on the American Board of Medical Specialties and the ACGME that have their own private rules and more like Guild, that's very limiting. So, for instance, we would look at, for the board to examine the American Board of Physician Specialties that has been around for about half as long as the ABMS. And so we do think that this process has worked, but we understand you might want to exit this process, but we urge that you do not do that until we have this alternative process in place.
Thank you. Jennifer, my understanding is that the ones who are already in the application process will be evaluated within a year or something?
Yeah, I believe Senator Hill did mention at our hearing that he was going to do a delayed implementation date of a year. I haven't seen the actual language, but it's something that was mentioned at the hearing.
He was sitting right next to me when the bill was presented, so that's what he mentioned. So we'll take a look, but I just want you to know that just like we are getting out of accrediting medical schools, we are getting out of, hopefully, getting out of accrediting the boards other than the what nationally accredited things are. Thank you, though. Any, Ms. Feldman? Last word?
Thank you. Julie D'Angelo, Falmouth from the Center for Public Interest Law. You know, these excessively lengthy investigations don't benefit anybody. They delay the filing of the accusation, which is what protects patients because that's a matter of public record. They certainly don't benefit the physician who has to operate under a cloud for an artificially lengthy time. We have to do something to lower these investigative times. You've heard Mr. Chris from the department talk about this pay differential proposal that he's had in the works at the state's personnel agencies for many, many years. You've heard me say that was actually in legislation. That was in legislation and legislative intent language in 1990, that whoever investigates your cases and wherever they are located needs to be paid the same as DOJ special agents, which is what they call their investigators at the Department of Justice. Might it be appropriate to include that, to suggest that as additional legislative intent language in this sunset bill? Thank you.
Thank you, Ms. Feldman. Any other public comment? Ms. Castro?
Good evening, Gloria Castro, Senior Assistant of Health Quality Enforcement. I just wanted to echo some of what Ms. Kirchmeier was trying to articulate. Quite frankly, the investigators did enjoy prestige by being associated with the medical board. They lost that when they were sent away. And having 3 state agencies involved in what is admittedly a very complex process over very important cases adds to frustration to our investigators who do a lot of work on your behalf. If you did amend it to include the suggestion that perhaps it would be a good idea to return the investigators to their home, which is the medical board, it would facilitate the discretion that is trying to be applied to vertical enforcement, topic by topic. And with that said, that was my comment. I did not hear anything about BMP 2006, but maybe we could talk about it later. Thank you.
Thank you, Ms. Castro. One more. Yes, ma'am, come on in. I was wondering when you're going to be coming up here.
I knew I was going to get in trouble, huh, Kathleen?
Kathleen, please go ahead.
Kathleen Nichols, Deputy Chief for the Health Quality Investigation Unit. And I'd just like to say that the investigators, we still believe we are medical board. We do all your casework. We are still there 110%. We work very closely with your executive group. And I think at this point, the investigators, I don't know that tugging them back and forth is the answer. They need to be paid appropriately, and I'll be providing an update on that tomorrow. So that's some positive news. But I'd just like to say, I think that pay is very important. Modifications to vertical enforcement are very important for us to retain the staff that we are now hiring. We are in a massive hiring cycle right now, and what we need to do is retain that staff. So that would be my position. We still, Dr. Ganadev, we still believe we work for you. That's who we are. And as far as an official position, the Department of Consumer Affairs would have to give the position on that. But I just don't know if any more disruptions would really benefit the process, and that's my input.
Thank you, though. We always look at you. You're our people. So, and remember, one of the it's late, but the guru who wrote books on MBAs. If there is something doesn't work, every organization has to look at something called organized abandonment. So this experiment did not work in our mind, so it got to go back. Thank you. Jennifer, any more comments?
Nothing else to add, just.
Okay, so we have a motion made and seconded. And any comments on the phone? That's the only one I haven't taken.
No comment.
Thank you. So roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Aye.
Ms. Lawson?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Mr. Warmoth?
Aye.
Ms. Wright?
Yes.
Dr. Yip?
Aye.
Dr. Ganadev?
Aye. Motion passes. Jennifer, you got one more item, then we adjourn.
Yeah, 7B is the status of regulatory actions. The matrix is in your board packet under tab 7. Do any members have questions on the regulatory matrix?
Any questions to Mr. Moss? Any comments from public, audience here? Any comments on the phone?
Comment.
Okay, so, so we actually have a slip. So are there any comments on the legislation we didn't talk about? There were 3 bills we did not, so.
I have a slip from a speaker on one of the bills we didn't talk about. Are you okay with not? Yeah, okay.
Thank you, Jennifer. It's a tedious process. I think I'll take one more item before we leave because somebody might be here and we don't want them to come back tomorrow. Item number 8, update from the Department of Consumer Affairs, which may include updates pertaining to the department's administrative services, human resources, enforcement, information technology, communications and outreach, as well as legislative and regulatory policy matters. Mr. Burke.
Thank you very much, Dr. Ganadev, although I will be here tomorrow regardless.
Thank you.
For fitting me in today. My name is John Burke, and I'm a manager with DCA's Board and Bureau Relations team. Thank you for the opportunity to update you on the activities of the Department of Consumer Affairs. In February, Governor Brown appointed Alexis Podesta as Secretary at the Business Consumer Services and Housing Agency, where she has served as Undersecretary since 2015. Also in February, DCA Director Awet Kadani accepted a new opportunity. Governor Brown appointed Dean Grafilo as Director. Prior to his appointment, Director Grafilo was Chief of Staff to Assemblymember Bonta since 2012. This is a homecoming for Director Grafilo, as he was formerly a commissioner with the California Athletic Commission. Director Grafilo joined the department on March 20th, 2017, and we're very excited to have him on board. Your executive officer will be receiving an invitation to meet with Director Grafilo very soon. The department hosted its executive brown bag gathering on Tuesday, April the 25th. As you may remember, brown bag gatherings are an opportunity for executives throughout the department and boards to network and collaborate on issues. Tuesday's agenda included a presentation on how to constructively manage difficult or confrontational conversations, as well as a panel discussing the regulations process. Looking forward to next month, the governor's proposed changes to the 2017-18 state budget, also known as the May Revise, will be announced soon. The deadline for the legislature to approve the state budget is June the 15th, 2017. Also in May, the department will release its new strategic plan. Like the board's strategic plan, the department's executive team developed it with the assistance of Solid, and it outlines DCA's goals and objectives for the next 4 years. When the new plan is released in May, we will email it to all board members, so please be on the lookout for it. Regarding the BREEZE system, testing is underway for a standard BREEZE software release that is set to deploy May 24th. The board has 13 requests for system changes in this release. The previous BREEZE software release was deployed on March 29th and also included 13 board requests. As of April 19th, there are 66 outstanding board requests for BREEZE system changes that are not yet scheduled for resolution in an upcoming software release. The new license lookup feature, which has been developed by the board and DCA staff, is scheduled for release on September the 30th, 2017. A word on trainings. I'd like to take this opportunity to thank the board members for completing the annual Form 700 earlier this month. And finally, I'd like to remind you that 2017 is a mandatory sexual harassment prevention training year for DCA. This means all employees and board members are required to complete this training in 2017, even if it was completed last year. This training is online, interactive, and can be completed at your convenience. If you have any questions on this or any other training during your tenure as a board member, please contact the Board and Bureau Relations team. This concludes the DCA update. I'm happy to answer any questions you may have.
Thank you, Mr. Burke. Actually, thank you for all these training programs, which I think I don't know how many times we've done. Any questions from the board members? Any comments from the audience? Any comments on the phone?
Comments?
This concludes this item. Thank you, Mr. Burke, for staying, and I'll have a motion to adjourn.
Motion to adjourn.
And the remaining items will be presented tomorrow. Thank you.